Good afternoon and thank you everyone for joining us today. I am Ankit Dogra with my teammate Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd. Delighted to welcome you all to the 6th MAMC MFM Virtual CME 2022 on Inverting the Pyramid of Antenatal Care, organized by the Department of OBGY, Maulana Azad Medical College, NARCHI Delhi chapter in collaboration with AOGD Fetal Medicine and Genetics Subcommittee Society for Fetal Medicine Delhi chapter. The academic partner for the today's program is Jagsonpal Pharmaceuticals Ltd, makers of LycoRed Preg sachets of L-arginine, lycopene and DHA for high-risk pregnancies, with EndoReg tablets of 2 mg dienogest for the medical management of endometriosis and endometriosis-associated pelvic pain. We thank Dr. Asmita M. Rathore, ma'am, the organizing chairperson and director professor, Maulana Azad Medical College, for involving Jagsonpal Pharmaceuticals Ltd in this program and passing baton of NARCHI Delhi Office program. A warm and hearty welcome to all the esteemed faculty and attendees. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on the Facebook and the link is shared in the chat box. To refer to this webinar in future, visit our YouTube channel, Jagsonpal Medical Insight, as complete recording will be uploading there. Now, I request MOC Dr. Niharika to kindly initiate the program. Over to you, ma'am.
You have to pass the baton. Everyone takes a turn and chips in. That's what great teams are for. I now invite Dr. Asmita Ma'am, President NARCHI and Head of the Department, Obs and Gynae, Maulana Azad Medical College, to please deliver the welcome address.
Thank you, Dr. Niharika, and a very good afternoon to everyone. On behalf of Department of Obstetrics and Gynae of Maulana Azad Medical College, I welcome you all for this 6th Maternal Fetal Medicine CME, which is an annual event for the Department of Obstetrics and Gynecology. The topic for this year's CME is Inverting the Pyramid of Antenatal Care. It's a concept which revolutionized and changed the focus of obstetrics and antenatal care from peripartum period to the early pregnancy. All the faculty is going to deliberate on this particular important topic, and I am sure the efforts of organizing team will benefit all of us. This particular CME has also one special component, that is the NARCHI office for the period of 22-24 is being taken over by Dr. Manjupuri and team Lady Hardings, and I take this opportunity to congratulate and convey my best wishes to the new team. We took over NARCHI office for the tenure of 2022 from team Sabdarjung and led by Dr. Achala Batra, who set not only a very high bench for mark for us, but also supported us throughout our journey. This was a mammoth task to be done in addition to our heavy clinical workload and the limitations due to COVID pandemic. The faculty of the department has put a lot of hard work and really worked tirelessly over the last period of 2 years, and ably led by the team of office bearers, Secretary Dr. Sangeeta Gupta, Joint Secretary Dr. Niharika, Dr. Chetna, our Treasurer Dr. Madhvi, our editors Dr. Sangeeta, Dr. Shakun and Dr. Pushpa, along with all our faculty members. This journey was also facilitated and guided us by the team of our NARCHI headquarters, our National President Dr. Kalol, Secretary General of NARCHI Dr. Dawn, our patrons, our executive committee members, and all the senior members of NARCHI and other professional bodies. So I take this opportunity to thank everyone who walked with us in this journey, and I hope our NARCHI members are satisfied with whatever we could deliver to them over the last 2 years. My special thanks to Dr. Batra and Dr. Tripathi, who were not only the pioneers in starting the subspecialty of maternal fetal medicine in this department, but also stimulated us to take over the office of NARCHI for the first time in MAMC. And so again, on behalf of team MAMC, I welcome you all, and over to Dr. Sangeeta Gupta for the Secretary's report.
Recording in progress. Good afternoon, everybody. It is my proud privilege to present the report of NARCHI Delhi Office 2022 to 2022. The office was born by Maulana Azad Medical College. Our heartfelt thanks to our patrons, Dr. Urmil Sharma, Dr. S.N. Mukherjee, Dr. Swaraj Batra, and Dr. Kamal Bakshi for guiding us all through. We also would like to thank Dr. Dawn, Secretary General NARCHI, and Dr. K.K. Roy, National President NARCHI, for their unconditional support, and they were always around whenever we needed them. The beginning of the journey was in December 2020, when we were handed over the office by Safdarjan team, and we have worked on the motto of empowered women, enriched society. That was the logo which we had chosen to work on. The key event during our tenure was the 27th annual conference of NARCHI, which was a virtual event due to the COVID pandemic. However, despite that, we had about 350 delegates who had registered for the conference with a star-studded faculty of about 80. There were 5 pre-conference workshops, 20 handpicked scientific sessions. We had the privilege of having Sir Arul Kumaran to give us the oration. We had the legendary Sheila Mehra quiz, and the winners were given a FIGO complimentary registration. We had the release of our e-souvenir, and there were about 130 papers presented during this conference. These are the few glimpses of the same conference. Now, the landmark achievement during our tenure was that we had conducted a session in the FIGO World Congress 2021 on pregnancy and COVID-19. And this session would not have been possible without the support of NARCHI headquarters. So we thank Dr. Dawn again. Then, despite COVID, we had continued with the training of teachers program along with the Directorate of Family Welfare, Government of Delhi. We had trained the ASHA workers, we had trained the ANMs, and we had also collaborated with them in the World Population Fortnight, which was conducted in December 2021, where we had sensitized people for male vasectomies, and we had conducted nukkad nataks. There were programs which are both online as well as offline. A unique initiative which was taken up by the NARCHI team in our tenure was cesarean section audit in collaboration with the Directorate of Family Welfare, Government of Delhi. And we thank Dr. Monica Rana and Dr. Jyoti Sachdeva for facilitating this project, and Dr. Reva Tripathi spearheading this project. Many private and public sector hospitals from Delhi have joined us in this endeavor. Despite the pandemic, we were able to conduct about 30 CMEs and webinars. These are few of snapshots from whatever academic activities we had done. Then we had also conducted educational series for the postgraduates, and there were many outreach activities also. There were awareness programs, there were health talks, there were nukkad nataks. These programs were conducted both in offline as well as online. We had focused a lot on youth awareness and empowerment, where we had sensitized the girls and teenagers about menstrual hygiene, adolescent health, sex education. And we had also conducted many screening camps on cancer and thalassemia. And for all these activities, we are very thankful to the Department of Pediatrics and the Department of Community Medicine of Maulana Azad Medical College. We have a very live and active website which is managed by Dr. Pushpa and Dr. Shalini Shakrawal, and I thank them for all the support they had extended for this. In bringing out these excellent e-bulletins, we must congratulate Dr. Sangeeta, Dr. Shakun, Tyagi, and the whole editorial team. And these are the 4 which we published. They were all e-bulletins, so we had tried to be green friendly this time, and there's still one more to come. And last of all, we added 158 new members to our family, and now we are a family of about 1150 members in NARCHI Delhi team. And I thank you all again, and I take this opportunity to thank the patrons and the headquarters again. I also thank all the office bearers, the executive committee and the outreach committee members. I thank Dr. Achla Batra, the past president of NARCHI, for helping us. Most of all, I thank all the members who have joined us in this endeavor. I also thank all the institutions with whose support we had conducted all the activities. I have my deep gratitude for the Honorable Dean MAMC and Medical Director LNH, the Department of Pediatrics and Community Medicine from MAMC, our academic partners, and last of all, Dr. Asmita Rathore, and my right and my left hand, Chairman.
Thank you so much, Sangeeta ma'am, and you have been a pillar of support for all of us. Thank you so much. So as it is said, the best leaders create legacy, pass the torch to the worthy ones. I am humbled to invite two such dynamic team leaders, Dr. Asmita ma'am and Dr. Manjupuri ma'am, for the official ceremony of handing over of NARCHI Delhi Office.
वहां से निहारिका वहां से
Thank you, ma'am. I also request Dr. Sangeeta ma'am to present a bouquet to Dr. Sharda Patrick.
So, a very good afternoon to all of you. And it is indeed a great privilege and honor to be here and taking over this office of NARCHI. Dr. Asmita, Dr. Sangeeta and team have done a very, very wonderful, work. And it's actually, they have set very high benchmarks. So very high bars for us to kind of meet. All the programs which they did were wonderful, and we all appreciate that. They were very high on quality. It was not only the numbers. I think the quality of each of the program was unique. And they have actually taken the real objectives of NARCHI forward. So they have looked at community level. They have involved so many other people who are actually what NARCHI wants. So they've actually taken forward all those objectives and aims of NARCHI. And me with my team, we will try and give our best. I cannot say we can. I will try to match their bars which they have set. We may not be able to exceed, but well, we will definitely try to match what they have done. So I have with me my secretary, Dr. Sharda. We'll have our co-secretaries, Dr. Swati and Dr. Kanika. Could you please stand? Yeah. So Dr. Swati and Dr. Kanika. I have my treasurer as Dr. Shilpi. She's not here, and Dr. Dipika will be the co-treasurer. Then we have our editor, Dr. Vicky. She's going to be the editor. And we have a special secretary for outreach activities, and that is Dr. Manisha. She's the special secretary. So I'm looking forward to work with my team and try and give you our best.
And moving ahead, and we wish you all the best and congratulations to the new upcoming team. And we are privileged to have with us Dr. Suraj Patra ma'am today, and ma'am has been the former head of the department and medical superintendent of Maulana Azad Medical College and Lok Naik Hospital. She has been instrumental in starting the fetal medicine department in our institute, and has also been the pioneer in bringing the NARCHI office to MAMC. So we seek your blessings, ma'am, and we invite you to say a few words.
Good afternoon, friends. I was never a president of NARCHI, but credit goes to Asmita Rathore for making me patron. Asmita Rathore, with her team, is running the office diligently and wonderfully. 3 cheers for Asmita Rathore. Thank you. I congratulate and best wishes for incoming team, and Dr. Manjupuri, I am sure will take the greater heights for NARCHI. Thank you.
Thank you so much, ma'am. Thank you. So we move ahead with our next program, the CME. For this, I would like to invite Dr. Harshiba Kaur, our very young and dynamic and very charming FNB fellow. So I hand over to Dr. Harshiba now. Dr. Harshiba, please.
Good afternoon, everyone. It is my absolute honor to welcome everyone to the 6th MAMC Maternal Fetal Medicine Virtual CME. The theme of the CME is to invert the pyramid of antenatal care. It is an essential concept in modern day obstetric practice. It aims at comprehensive and focused antenatal care in the first trimester and emphasizes that this is the most important visit for risk stratification, prevention, and further management of pregnancy. I would request you to type your questions in the chat box and we will answer all the questions at the end of the CME. And we are honored to have our experts of the CME, Dr. Pratima Mittal and Dr. Seema Thakur. Dr. Seema Thakur, ma'am, she is a respected senior consultant at Genetic and Fetal Diagnosis Center, Fortis Hospital, Delhi. She's a current chairperson of AOGD Genetics and Fetal Medicine Subcommittee 2021 to 23. Also current vice president BGF Dwarka and also has a vast experience in genetic counseling and prenatal diagnosis. I welcome ma'am.
So Dr. Seema is also the chairperson of the AOGD Genetics and Fetal Medicine Committee, and she is a very, very approachable clinician. And I would like to talk a little about the CME. When we had conceived this CME, we just wanted to apprise all our obstetrician friends about what they should know in day-to-day practice, which is evidence-based, which is logical, which is practical. And it is my request particularly to the residents that whenever you approach a patient in your setting, please don't blindly follow the guidelines. Guidelines are there to guide and we must adapt them to our setting. So that was the objective of bringing this CME. The topics appear to be very basic, but the challenges which we face in our settings is that very few patients are coming for preconceptional care. The patients who are coming in the first trimester, we are not focusing on our own problems, like our hemoglobinopathies, which is hardly seen in the West, preeclampsia, which is a major killer, and diabetes, which has become the latest pandemic, I think, in obstetric practice. And besides that, whatever care we give in the first trimester is suboptimal, even with what we have. So that was the objective. And the other issue which we have in our setup is, particularly the public sector, is that the bookings are usually late. Very few patients are coming in the first trimester to us. They are usually coming in the second trimester, say around 5 months. And how to address these patients to optimize their care. So this was the whole premise of putting this CME together, and I hope we are able to fulfill the objective. So can we start the first session? Yes.
Dr. Pratima ko introduce kar.
Dr. Pratima Mittal, ma'am. Ma'am is ex-professor and HOD of Department of Obstetrics and Gynecology. Ma'am is ex-professor and HOD of Department of Obstetrics and Gynae, Vardhaman Mahavir Medical College and Safdarjung Hospital.
Hello, thank you.
She's honorary fellow of Royal College of Obstetrics and Gynecology, UK.
Ma'am, please.
Ma'am has done exemplary work in women healthcare. Ma'am is teacher par excellence with many accolades to her name. Welcome, ma'am. Ma'am is a senior consultant fetal medicine at Cloud9 Hospital, Gurugram. She's ex-HOD and of obstetrics and gynae and the chief of maternal fetal medicine at AIM and the president of BGF Dwarka. I welcome Dr. Tripathi. Ma'am is HOD, Hamdard Institute of Medical Sciences and Research. She's ex-HOD at OBGY, MAMC and Loknaik Hospital, head of F&B program, maternal and fetal medicine, in addition to various other accomplishments. Welcome, ma'am. Dr. Aksha Batra, ma'am. Ma'am is Professor, Department of Obstetrics and Gynecology at Vardhaman Mahavir Medical College and Safdarjung Hospital, President AOGD, a dedicated PG and undergraduate teacher for the past 35 years. I invite our esteemed chairpersons to take this session forward, please.
I'm happy to welcome Dr. Shakun Tyagi to deliver this lecture. I've known Shakun for I don't know how many decades, right from the time that she was a postgraduate student. And I'm very proud that she is now in the situation to deliver these lectures and teach us all what we possibly need to know and should have known quite some time back. But so Shakun is going to talk on preconceptional care, a stitch in time saves 9. Very appropriate. Dr. Shakun Tyagi, please.
Carrying on with the topic. Right preconceptional care is very important. It's very essential for a healthy baby, a happy mother, and also a safe gynecologist. Earlier we know and learn this, better it is, because it's just a matter of time that we are going to have our own eavesdrops who are going to sue their mother's gynecologists for not giving adequate preconceptional care. So, preconceptional care reduces the chances of adverse pregnancy outcome, and not only health education and promotion and risk assessment, and with a leading to an intervention before pregnancy. Because many a time, if timely intervention is not taken, even the 9 stitches will not be able to help. WHO in 2013 was a very comprehensive package of preconceptional care. It had 13 things, but still missed out on medical disorders and obstetric problems related to pregnancy. So all these I've divided them, rather summated them into 5 pillars, but these are not watertight compartments and may not be in the same sequence. So what I feel, the first is about spacing, dating and treating infertility. Next is regarding genetics, nutrition and environment. Third, related to infections, which deals with vaccination and screening of various infections. And fourth are the things which are hushed under the carpet: mood disorders, substance abuse, intimate partner violence, and we never talk about female genetic mutilation, because it's not relevant to our market. But what was missing in this WHO care package was past obstetric counseling related to past obstetric history and medical disorders. So the whole today's presentation will revolve around these 5 pillars. Recently, in 2019, we had guidelines on preconception care by ACOG and along with ASRM. And they were reaffirmed in 2020. And even FOXI came up with its good clinical practice recommendations in 2020. And again, FOXI came out in 2021. And this was convener was Dr. Alka Kaplani and coordinated by our own Dr. Aparna Sharma. So I've synthesized all those and I have not separately label them, which guideline is saying what. So who all women need this preconceptional counseling? According to ACOG and ASM 2020, any patient encounter with a non-pregnant woman or a man, that was very essential. Like, even if you went and encounter a man, you should give him a preconceptional care so that it can be conveyed to the partner also. So anybody with reproductive potential must be given this reproductive preconceptional counseling. And how should we go about? They should be asked would they like to get pregnant next year? Obviously, this question will be for the female. And what should be emphasized the first thing? We talk about fertility issues, and if she wants to get pregnant, and most importantly, this is the time to also highlight about dating. So every lady should mark the date of a period on a physical calendar or an app or a note, because if this is not emphasized pre-pregnancy, or most of the time dating is confused, and then we land up with imagining the period gestation when the complications arise, and even for other screenings, right dating is important. So it is very important to emphasize on dating. Very important, interesting thing they noted was any patient, infertile woman who's going about pregnancy, the inter-pregnancy period should be less than 18 months but greater than 6 months. Similar advice is important for patients who are previous cesarean, that inter-pregnancy period should be more than 18 months, preferably. So, coming to our second pillar was nutrition, environment, and genetics. Nutrition is very, good nutrition is very important. It includes macronutrients as well as micronutrients, and folic acid is most important option that cannot be highlighted more. So definitely dietary advice is important, but we can even strategize patients, the women, according to their risk factors, whether they need a routine folic acid intake, whether they are moderate risk of neurative defects, when they need to have 1 milligram per day. In case of family history of neurative defect in first or second degree relative, maternal diabetes or maternal malabsorption syndrome, or high risk of neurative defects, when 4 milligram per day of neurative defects, folic acid is required. So, who are these women who have a history of neurative defects in themselves or even their partner? Pregnancy, hemolytic anemia, BMI more than 30, women with no methyl tetrahydrofolate reductive mutation, hemoglobinopathies like beta thalassemia, or medication affecting folate metabolism such as anticonvulsant. So this is very important to prevent neurative defects. And now we have methyl tetrahydrofolate available as such, and this might be given to patients with women with methyl tetrahydrofolate mutation to prevent recurrent neurative defects. And then other iron supplementation, we all know weekly iron supplementation is required in non-pregnant women, along with albendazole as required. Now, what about vitamin B12 and vitamin D? Ideally, women should be advised good diet which have all these elements, and we should not routinely do these levels, vitamin B12 and vitamin D. Although we see that most of our population is strong deficient in these vitamins. We already know about iodine supplementation, 150 micrograms per day is required. About abnormality of macronutrients. So even abnormal high or low BMI is associated with infertility, but can also lead to maternal and fetal pregnancy complications. So, apart from diet, exercise is very important. Now, who all women require genetic counseling? Either they are known or suspected hereditary disease, advanced parental age, there is steroid exposure or infection during early pregnancy. Like thalassemia is more common in North India, so these women require thalassemia screening. Presence of birth defects, chromosomal abnormality, intellectual disability, development delay in parent, a child, or a child of a family member, then recurrent pregnancy loss, and if this family history of early onset cancer like breast, ovarian, uterine, colon. So this opportunity should not be lost to prevent other genetic genetically causes problems, and we should not orient only for preconceptual counseling, and it should be a holistic approach. Apart from pedigree analysis, if it is not available, then at least the following need to be charted. That is consanguinity, family history of birth or gene defects, and history of recurrent birth. Ideally, we should have pedigree analysis of 3 generations in all our patients. Now, what about environmental exposure? So, at home, we are bombarded with plastics which have bisphenols, and bisphenols have adverse pregnancy outcome. Meta-analysis has shown, and it has a negative impact on birth rates of preterm birth, developmental defects, and recurrent miscarriages. Not to talk about pesticides, lead, asbestos, and even at work, agricultural workers are exposed to pesticides, organic solvents, heavy metals are in higher quantities in areas in manufacturing units. For women working in dry cleaning areas, solvents and our healthcare workers are exposed to various biological agents and radiation. So all women should be counseled regarding these environmental factors during preconception. Now coming to infections. Now certain infections are suggested by ACOG, but all of them might not be relevant to us. Tdap annually has been suggested by ACOG. However, our women take their first dose of tetanus during pregnancy. When annual Tdap is being given to these women, they get 1 dose of Tdap just in around 26 to 36 weeks of pregnancy, which protects both the mother and the baby. However, we in Government of India guidelines states that we give TD, that is tetanus and diphtheria, for these women, and 2 doses are advised. If the patient is not being immunized for hepatitis B, that should be given during pre-pregnancy period. We are not giving varicella, and if patient is comes under the group of women whom HPV vaccine is recommended, this women should also be given HPV vaccine. Once it has been started and the next dose, when it falls, the patient becomes pregnant, it is advised that second dose should not be given during pregnancy, and further doses of HPV should be given after pregnancy. While talking of HPV, we must say that we should do cervical screening in these women as indicated. ACOG also recommends annual influenza vaccine that we are suggesting only during pregnancy, and COVID-19 during COVID-19 vaccine must be taken during the pandemic at least. Let's see how things progress and how further guidelines. But during the pandemic, preconceptional counseling must include COVID-19 vaccine. Now coming for screening for infectious disease. We are already screening all women for hepatitis B, syphilis, and HIV during pregnancy. Patient requires a Reva vaccine. Then it is very important to take proper history for tuberculosis and toxoplasmosis exposure, so that testing for and adequate prophylaxis or treatment is given to these women. Assessment is required for need of screening for sexually transmitted diseases at this time itself. So, after infections, the next pillar is for screening for the things which are asked under the bracket, like screening for intimate violence, partner violence. Women never talk about these, and it has been shown that intimate partner violence is associated with adverse pregnancy Should be routinely asked about the use of alcohol, tobacco, nicotine products, and drugs, including prescription opioids and other medications, as well as psychiatric issues. Now, the latest rather WHO guidelines did not talk about various obstetric history or the medical history, which is very important component of preconceptional care, because these are the things that need to be taken care of prior to when the patient gets pregnant. And in many cases, the disease may progress to harm the mother and might even lead to maternal mortality. Moreover, most of the medical disorders require a multidisciplinary approach. That is very important, and patient must continue follow-up of these chronic diseases with their doctor, the physician. So coming to previous pregnancy losses, if the patient has had recurrent miscarriages or even preterm delivery due to preeclampsia or FGR, or there has been IUDs, then various investigations has been recommended as part of preconceptional care. Now, testing for antiphospholipid syndrome is a very important component, and many a times we forego this. I just want to emphasize who all women require this testing. Not only women who have thrombosis, history of thrombosis, or 3 or more consecutive spontaneous abortions before 10 weeks of pregnancy, after ruling out any anatomical or hormonal abnormalities in mother or parental chromosomal causes, or one or more loss more than 10 weeks. But most important is this group, the women who have before 34 weeks of pregnancy, eclampsia, severe preeclampsia, or FGR due to placental insufficiency. These women, when they present to us and they deliver at the time of discharge, we must advise them regarding getting their antiphospholipid antibodies tested after 3 weeks, after 3 months, rather 12 weeks of delivery. Because when they present next time without these investigations, we are always wondering whether these women are ideal candidates for the therapy for antiphospholipid syndrome or not. And then we come to a situation where some women have started empirical therapy, others who need it do not get it, are leading to recurrent adverse pregnancy outcomes and losses. So it is very important that at the time of discharge of a patient who has had adverse pregnancy outcome, all these things must be emphasized. So we already talked about multidisciplinary approach in case of all medical disorders. Now briefly we'll just go through how should we go about with all the various, if the patient is a diagnosed case of various medical disorders. We all know diabetes mellitus, whether it is IDDM, juvenile or type 2 diabetes. These women need good sugar control. They should be taught self-monitoring, and HbA1c must be less than 6.5 before planning the pregnancy. They should continue their management with the physician, and even after pregnancy, they should continue with the medication. However, oral hypoglycemics, some of the oral hypoglycemics are not conducive in pregnancy, and they might require change. Thyroid disorders also need management during pregnancy. In cases of hyperthyroidism, we basically have to decide about not giving methimazole. during first trimester, and propylthiouracil is the drug of choice during first trimester. But during second trimester, methimazole becomes the pregnant drug of choice. But we very seldom see patients of hyperthyroidism. Mostly of our patients are hypothyroid. And we are a belt of iodine deficiency in spite of the salt being fortified with iodine. Iodine deficiency is prevalent. So the diet must be such that at least 150 microgram of iodine is taken. Now, it is desirable to have universal screening for hypothyroidism. However, when it's not available, case finding approach has been recommended, where symptomatic women from areas of known moderate to severe iodine deficiency, like hilly areas, family or personal history of thyroid disease, type 1 or type 2 disease, history of miscarriages, preterm delivery, history of head and neck radiation, and morbid obesity must be screened for hypothyroidism. And these women must be told that TSH more than 2.5 will be optimum. And as they become pregnant, there will be around 30% increase in the dosages of levothyroxine once the pregnancy is confirmed. What about hypertension? When these women who plan to get pregnant come to us with hypertension, we need to rule out secondary hypertension. Any renal disease, autoimmune disease, or thrombophilia, which is cause of this renal disease, as well as look for end organ damage in form of ventricular hypertrophy, retinopathy, or even urine protein ratio for renal issues. We need to be advised as they become pregnant. The drugs will require change, and ACE receptor blockers and ACE inhibitors both are contraindicated and need a change. And maybe this can be done prior to pregnancy when the patient is planning a pregnancy, rather than going with these drugs into pregnancy. A heart disease, a very small, selective, but a very important group of women who require very multi-speciality and close care. The women with congenital maternal heart disease require genetic counseling. Those women who are taking more than 2.5 milligram per day of warfarin will need switchover in first trimester. And this subset of women who should be told that they should not get pregnant and must use adequate contraception. These are severe pulmonary artery hypertension of any cause, severe systemic ventricular dysfunction, left ventricular ejection fraction of 40 millimeters of mercury, or aortic dilatation more than 50 millimeters, and a disease associated bicuspid aortic valve and native severe coarctation. Moreover, if any surgical correction is required, like BMV or valve replacement, that must be done pre-pregnancy itself. Seizure disorders, these women must be switched over to a safer anticonvulsant after consulting a neurologist, and currently in vogue is levetiracetam. Everybody who goes to a neurologist is subscribed levetiracetam. And so it helps in getting us to anticonvulsant monotherapy, and we should aim at the lowest effective dose. And patient should be at least seizure-free for 6 months. And she must be told that even if the drugs are harmful for the baby, she should not stop, because having a seizure will be more harmful than the drug itself. Then these women who have had cancers. Now, in these, the pregnancy outcome they should be advised that it will depend on the type and stage of cancer and what are the complications of therapy. And young patients with cancer should be counseled about the effects of cancer treatment on fertility and pregnancy outcomes. And they must be given options of preservation methods like cryopreservation of sperm for adult male and embryo and oocyte for adult female, depending on the age and type of cancer and the treatment of cancer. And towards the fag end, we also have women who have autoimmune disease and they plan to conceive, and they must be told that drugs like methotrexate, cyclophosphamide are teratogenic and should be avoided. And we have better options like azathioprine and tacrolimus. Even hydroxychloroquine, which is given in SLE, is safe during pregnancy. So women with SLE might have spontaneous abortion, preterm labor, FGR, superimposed preeclampsia, and if ROLA positive, then congenital heart block. So these women must be told that there could be higher chances of adverse pregnancy outcome in this. However, there will be need for continuing drug therapy during pregnancy and even after pregnancy, and close follow-up will be required. So summing up, for genetic disorders, I would suggest from preconceptional counseling, we would go to premarital counseling. So the couple must, all couples must, would-be couples must check out with geneticists to check out whether they are at higher risk, do they need any testing, should they get married, rather than we matching their kundalis, which we should get them to see a genetic counselor to see whether they should get married or not to have a healthy progeny. And these 5 pillars which I talked about should support the preconceptional care: the spacing dating, the environmental genetics and nutrition. Then we have infections, which includes vaccinations and screening of various vaccines. Then the rarely seen things, which we just don't talk about: the intimate partner violence, the psychiatric disorders, the mood disorders. And one very important thing I want to emphasize again: we should utilize the time of discharge of the patients who deliver with us for preconceptional counseling for future pregnancy, as we talk about contraception, but we do not talk about future pregnancy. We should utilize this time. And best wishes for upcoming Holi, and thank you for patient listening. I think hopefully I completed on time.
Yes, very nice.
For the very crisp your questions. In the next session, we'll have a panel discussion on comprehensive.
Chairpersons ke comments.
Can I actually pass a few comments as an expert? I mean, chairperson?
Yeah, sure, ma'am. You're welcome.
Yeah, actually the time got changed. I think I was not intimated, so I'm sorry I'm late. I came for 2:30. Yeah, this is about preconceptional counseling. So I think one of the very important preparedness is as she talked about medical history, but you have to give a little percentages. And I came in at the time of anti-Roe, anti-law. So I have seen people, counseling them that they have absolutely no chance, but it must be said that his risk is just about 2 to 3%. And then the screening, you need to do, like yesterday I was in another meeting and patients who have a previous preterm labor and all. So you really need to see the cervix. Physical examination is very important. And you may do any investigations that is required to document uterine or a cervical incompetence. And very important nowadays is the mental health. We seldom look into that, but it's very important that we should also look for the mental health and counsel for the pregnancy. Tell them about what you're expecting, what are the tests that needs to be done and everything. And of course, we are not routinely doing a TORCH test, but I have seen too many cases where even now in big hospitals and high socioeconomic status hospitals, patients are detected to have infections late in pregnancy, congenital infections, which if it was done preconception, just a baseline would have really helped in the counseling. So otherwise, it was quite very informative lecture.
Thank you, ma'am. Thank you for your kind words.
Dr. Achla
Dr. Achla Batra, have any comments?
I think that the paradigm for antenatal care is going earlier and earlier. As she said, preconception and then premarital. So it's something that we all need to orient ourselves to ourselves. and try and see that we make use of any opportunity whenever we get a patient, appropriate patient in the OPD. And I'm glad Shakun has also included men. I think it's kind of unusual to add that, but yes, you're very right that they do need to be included in the spectrum also. Thank you.
Holistic care.
Yes, holistic care. That's right.
Thank you so much, ma'am. Can we move on to the next session? The next session.
Actually, now there is, it's coming the era of the whole exome sequencing. And we do see a lot of cases, men with chromosomal inversions, duplications, especially patients with recurrent abortions.
Thank you, ma'am.
Thank you, ma'am. The next session will be a panel discussion on comprehensive first trimester care, catch them early. This is moderated by Dr. Kanwal Gujral and Dr. Sangeeta Gupta. A few words about Dr. Kanwal Gujral. Ma'am is the chairperson, Institute of Obstetrics and Gynecology, Sir Gangaram Hospital, New Delhi. Ma'am is in charge of high-risk pregnancy clinics and past president of NARCHI as well. Dr. Sangeeta Gupta, ma'am is Director Professor of Obstetrics and Gynecology, Maulana Azad Medical College. Ma'am has established fetal medicine services at Loknayak Hospital and is a Commonwealth welfare scholar. Ma'am is also Secretary of NARCHI. I request the moderators and panelists to please start the session.
Good afternoon, everybody. The topic for today's panel discussion is inverting the pyramid of antenatal care. And for this, I have a galaxy of panelists. Dr. Angela Neja, who's the Director and Head Minimal Access Surgery at Fortis, Gurgaon, and an astute clinician. And her mantra is that she has a very pragmatic approach to all the problems. Then we have Dr. Professor Aruna Nigam from Hamdard Institute of Medical Sciences and Research. And she's an editor-in-chief of Pan Asia Journal of Obs and Gynae. And we are all well aware of her teaching skills. We also have Dr. Chanchal with us. We are very proud to have her. She's a lead consultant in fetal medicine. And almost everybody knows Dr. Chanchal in the field of fetal medicine. We also have Dr. Indu Chawla. She was the ex-HOD at Department of Obs and Gynae, RML Hospital, New Delhi. Her area of interest is gynae endoscopic surgery. And she's another person who's very practical and patient-oriented, gives, logical patient-oriented care. We are very honored to have Dr. Ranjana Sharma also as one of the panelists. She's a senior consultant at Apollo Hospitals, a very famous urogynecologist, and currently the chairperson of AICC RCOG North Zone. And last of all, Dr. Vatsala Dadwal, who's the lead of Division of Maternal Fetal Medicine at the Apex Institute of All India Institute of Medical Sciences, New Delhi, and a role model for every maternal fetal medicine specialist. Welcome all my panelists. And with this, I hand over to Dr. Gujral.
Good afternoon, everybody. Congratulate the organizers for putting up this very brilliant program. Now, friends, you'll be aware that past 80 years, antenatal care involved just one checkup in the early parts of pregnancy. And as the pregnancy advanced, the last trimester had the maximum number of checks. Now, LycoRed in 2001 inverted this pyramid of care with the view that at 12 weeks of pregnancy and the first trimester, you can diagnose things which are existing there, like anomalies, like chromosomal disorders, and also predict, catch the women who are likely to develop evolving disorder, let's say hypertension. Therefore, a 12-week scan is the most important scan as of today. It will categorize women into low risk and high risk. The high risk women requiring, special care, therefore being referred to high risk centers or the fetal medicine centers. Now, keeping all this in mind, we made a panel discussion, a case-oriented panel discussion. We will deal with the basics as well as the little high-end cases. And Dr. Sangeeta, I must say, she's worked very, very hard on making this panel. We had meetings and meetings, and I hope you all like it. And I just did a wee bit of topping up. All yours, Sangeeta. Start with the first case.
Thank you so much, ma'am. So just to begin with, accurate gestational age is one of the most critical informations which we require during pregnancy, and it influences all decisions throughout the pregnancy, particularly while evaluating the growth and timing of delivery. Now, we are in a world which is very fast evolving with technology, and most of us have resorted patient care also completely to the investigations. However, we should not forget that still the maternal characteristics and history form the basics of screening for any patient, and it determines the a priori risk in not only the established algorithms like for aneuploidy or preeclampsia screening. However, it is also very important where algorithms are not defined, and we need to pick up the high-risk patients from this category only, and it is very well demonstrated in this forest plot. So coming to case 1, she's a 29 years primary, low risk, with 10 weeks of pregnancy, no complaints, with a BMI of 22 kgs per meter square. So Dr. Aruna Nigam, what maternal and fetal disorders would you screen for in the first trimester?
Thank you, madam, for giving me invitation for this panel discussion. So something you can catch and something you can predict, right? So maternal disorders, which we are usually doing, and few we can predict. So the maternal disorders foremost is the anemia, which we always do with the CBC, and thalassemia we can do, RH status, thyroid disorders, infections like HIV, HPSAG, HCV, VDRL we can do, urine infections, gestational diabetes mellitus, which is very much prevalent in our society, so that should also be screened. And preeclampsia screening, lot of prediction models are also available with the preeclampsia. Then preterm labor, fetal growth retardation, and macrosomia prediction model has been given by FMF. Then regarding the fetal disorders, which can be done are fetal aneuploidies and fetal structural defects, which can be predicted by few of the ultrasounding scans, moreover, and the biomarkers also.
So these were the investigations with which the patient had come, which is a routine in any antenatal clinic. So I would like to have your comments on the bloods of the patient.
Okay.
Are you happy with this? You want to add something, or you want to delete something from this list?
Yeah. So it's good to have a hemoglobin, but it would have been better if I would have got a CBC, right? So why CBC? Because CBC can predict, gives you a RBC indices where MCV is there, and if MCV is less, you can think of a thalassemia. But HPLC is better to predict other hemoglobinopathies also, like HBS, HBS, C, and E. Moreover, besides thalassemia, can we go back? Yeah. So infection panel has been covered. Blood sugar fasting PP is there. So that is a good idea. And we can also go for a OGTT rather than going for a fasting PP. But fasting is also good. Few people say, few of the guidelines are nowadays saying go for a fasting and HbA1c. So that can also be done in this case. And TSH, I think we have already done.
Yeah. So to summarize, the best test to do is HPLC, but there may be logistic issues in setups where at least the RBC indices and Menzel's index is a must for all of us. Since we all know that hemoglobinopathies is a... I don't know, ma'am, they are able to see, everybody is able to see.
Yeah, we are able to see.
Yeah. So we know the burden of hemoglobinopathy is quite high in our society, in our setup. Then the ideal time would be a preconceptional screening. However, there are, this is not a popular method. So preferably before 8 weeks. And if the patient comes late, it would be a good idea to simultaneously check the couple. Screening of diabetes mellitus should be opted for at the first contact as per the Government of India guidelines, and the test to be, which has become most practical, is a DIPSI 75 grams 2 hours, irrespective of the time of intake of any food. And there is a lot of debate about thyroid function tests. Some are against universal testing and some recommend. However, as already summarized by Dr. Shakun, since we are having a high burden of gestational diabetes in our setup, we can opt for a thyroid function in all women. So this is the ultrasound done at 8 weeks of pregnancy in the same patient, which shows a single intrauterine pregnancy, a crown rump length corresponding to 7 weeks and 5 days. The cardiac activity is present and the fetal heart was okay. When the patient took the pregnancy further on, there was another scan which was advised at 12 weeks. This is the finding. That's a crown rump length corresponding to 12 weeks, 2 days, single fetus, cardiac activity present, NT&B seen, subchorionic hematoma of about 1.8 centimeters to 2 centimeters seen, and the cervical length was 35 mm. So Dr. Angela, could you just talk in short about the implications of a subchorionic hematoma visualized in this kind of a patient, no complaints in the first trimester scan?
Like if the patient comes to know about that she has a subchorionic hematoma, it's very important to find out whether she has a plain pain or a bleeding or this, it's nothing. It looks like it was an asymptomatic in this case. So whenever there is a bleeding patient, they are scared that they are going to have a miscarriage because of the subchorionic hematoma. The first and most important thing is to sit down and counsel with her. And there is always a debate whether, whether you should start some kind of progestogens or not. But yes, if there is a bleeding or if there is a pain, you can start progestogens, which is a dydrogesterone. Second important thing is to look into is how much is the hematoma. If hematoma is more than 25% of the volume of the sac, then the chances of miscarriages are higher, and or the site. If it's a subchorionic, if it's a retroplacental, then the chances of placental abruption in the follow-up, you need to look into it, that these are the patients who can go into a premature rupture of membranes, preterm labor. So it's important to warn the patient also. If there's a pain, if there is a bleeding, then you need to come to the hospital, and the most important thing is, everybody advise a patient a strict bed rest with the, legs up. That is not recommended. What we usually tell our patients is it's a restricted activity. Avoid exertion, avoid heavy weight lifting, and but she can get up from her bed, go to the loo, but just avoid unnecessarily extra work. If there is a subchorionic hematoma, which is of significant size.
Thank you, Dr. Angela. So, Dr. Angela, would you like to make some comments on the ultrasound picture which was projected during the 12-week scan?
Can you go back?
Okay.
So it was corresponding to the 12 weeks and 2 days only. So that was good. The NT is also fine. The nasal pose is also seen. That's also good. Cervical length is also fine. We definitely want to look into the uterine artery Dopplers also at this time, and other markers for the Down syndrome, like, there is a facial-maxillary angle and the tricuspid valve regurgitation and all those things.
Yeah. So, in fact, I would say that the image quality was poor, and it is requested that all of us request our ultrasonologists to send the images and we should look at the image. And CRL measurement should be mentioned in millimeters also, very rightly pointed out by you that the uterine artery Doppler was not there. I think this is something which we all need to address. We have become very thorough and very proficient in aneuploidy screening, but now we have to gear ourselves for the pre-eclampsia screening. Dr. Gujral will be talking in detail. There was no comment on anomalies, and what about cervical length, we'll discuss later. So this is an ideal image which...
So basically a transabdominal and a transvaginal scan, ideally, both of them should be done at 12-week scan. So that gives us almost 80-85% of the pictures.
Yeah. So Dr. Vatsala, I think you're the best person to give us a checklist of the first trimester scan, which is advised between 11 to 13 plus 6 weeks.
Thank you, Dr. Sangeeta. Thank you for the invitation to join this very important panel discussion. The questions are so basic, but I think it really set all of us thinking about the questions. So as advancement in imaging, and as more and more people are doing more in-depth imaging, there every year or every few months you find a extra parameter that can be seen on a scan. And the first trimester scan is going a big way in looking at fetal anatomy and going into depth of anomalies. but it has to be a basic thing that everyone should report for it to be a meaningful scan. So when we start doing the scan, then we have to look at the viability. We have to look at the number of the fetuses. We have to do the dating. So for that, CRL has to be measured in millimeters. And Dr. Sangeeta said that has to be done in a proper plane, mid-sagittal plane. The calipers have to be placed from the crown to the rump, and the edges where placing the caliper should be clearly visible. If there is more than one fetus, then it is very important that you look at the chorionicity, because there is no diagnosis of a twin unless you know whether it is monochorionic or dichorionic or what is the amniosity. Again, it is a good time to also look at the uterus and adnexa, because you may pick up fibroids. And again, the location may be important. Suppose it is a lower segment fibroid, or you may pick up a uterine anomaly. There may be a septum, there may be a pregnancy in a bicornate uterus. So that is important for counseling your patient, and also how you're going to plan the management further. So this is the basic. Then you go to aneuploidy screening, which all of us are doing. So what is important for aneuploidy screen is that the sonographer should be certified. Otherwise, you'll have those bad images like Dr. Sangeeta showed, and which are not meaningful. For the first trimester screening, the most important component is NT. If NT is not done properly, then we should not give any importance to that first trimester screening value that we're getting risk for aneuploidy. So NT-NB is a minimal. Desirable is looking at the ductus venosus Doppler and for tricuspid regurgitation. And uterine artery Doppler, yes, it will help us in calculating the risk of preeclampsia. And again, anomalies. What we should look for in the fetal anatomy is that you have to, there's a basic that has been, so if we see what are the anomalies that we should not miss, there's a long list of anomalies which can be diagnosed in the first trimester, and there are many which are not even diagnosed, but overall, at least 30 to 60% of gross anomalies are diagnosed in the first trimester, and we should not be missing anencephaly, alobal holoprosencephaly, large omphalocele and gastroschisis, megacystis, body stack anomaly, fetal hydrops, and a molar placenta. So what is the minimum that you have to report about the fetal anatomy? You have to have a section to the fetal head, look at the midline fork, the choroid plexus, to rule out basically acrania and holoprosencephaly. Then coming down, you have to have a look at the spine. Then in the thorax, you should look at the lungs and the heart. And in the abdomen, you should look at the cord insertion minimum. You can, if you see the stomach, it should be mentioned. Then you should look at the bladder. You should look at all the fetal limbs. So this is the minimum that is reported. If a sonographer is good, they can also look at the fetal face. They can look at the heart, the four chambers, the outflow tract, the kidneys, the bladder should be mentioned, and also at the digits and the limbs in more detail. So this is what it should be. But anyway, whoever is doing the scan, they have to give you the basic reports.
So very rightly said, Dr. Vatsala, some things are must know. We can't afford to miss them. Some things depend on the expertise of the person, the resolution of the machine. And of course, some of the anomalies would not be picked up in first trimester whatsoever equipment or whatsoever expertise we have. So moving forward, if only one scan has to be done in the first trimester, can you delineate the ideal time? Because in this patient, she had two. But with our constrained resource setting, maybe if we have to just pick up one.
I think the best time to do would be between 11 to 13 plus 6. I would say even if you have to do the scan, it's better to do around 12 to 13 weeks because the fetal anatomy is better delineated. And also if you want to date the pregnancy, so a CRL measured between 10 to 13 weeks and 6 days is the best time to date the pregnancy. And also you can also screen for aneuploidy looking in the nuchal translucency nasal bone. So this and uterine artery Doppler. So this is the optimum time. One scan gives you maximum information that you need.
Yeah, and what I would like to add here is that even if we do a scan before 11 weeks, we still would need to repeat another one between 11 to 13 plus 6. I think you agree with me there.
Yes. So I think it's unless a patient has the indication for doing a scan in the first trimester, like there's a history of bleeding, you're suspecting ectopic, or she had previous losses, it's better to time for one scan that can be done between 11 to 13 plus 6, which would be most economical also.
Okay. And I think this question you have already answered about the comment on uterus and adnexa. So moving further on to the aneuploidy screening, Dr. Ranjana, I would like to know what other tests would you advise to these patients, and any precautions while we are prescribing testing for aneuploidy? Yeah, welcome, ma'am.
Yeah, so thank you very much for giving me this opportunity, Sangeeta.
Ma'am, our pleasure to have you.
Oh, so whatever has been said, then if we add some biochemistry to the ultrasound findings, then we increase the sensitivity of the test. So we should add, PAP A and pre-beta HCG, and then if it becomes more expensive, but it becomes more sensitive if you also add PLGF to the screening panel. So for this, the precautions will be, to confirm the gestational age. That's very important because everything will be linked to the period of gestation and whether the patient has a multiple pregnancy or a single child. Then whether it was an IVF pregnancy or natural pregnancy. And if IVF, then whether it was a donor egg or it was a self egg, right? So that's also important because all can affect the PAP-A, the placental proteins. Then the transportation is also important because some of them will be heat labile. So we have to make sure that they reach the lab properly. And whether patient has had HCG injections, then that can also affect. Basically, yeah, something like this. Or maybe a hematoma, will that affect the change? Yeah. All right. Yeah. So these are the some things which should be taken, conditions should be taken into consideration when you interpret the results.
Yeah, thank you. Yep, we have added PHGF to this panel because when you're advising biochemistry, we are not looking at the patient as an aneuploidy. So it should be a holistic care. So when you are advising a biochemistry, if possible and if it is feasible for the patient, PLGF would be a good marker to screen her for preeclampsia, though it doesn't contribute much to aneuploidy screening. Besides whatever Dr. Ranjana has enumerated, a good software, selection of a good software is very, very approved software is very important. And we should acknowledge this, that it should be a combined screening, which should include both the biochemical markers and the ultrasound markers. So Dr. Chanchal, when is NIPT done? Is it used as a first or a second tier test?
Good afternoon, everyone. Thank you, ma'am, for giving me the opportunity to be with everybody on this Saturday afternoon. So the NIPT, ma'am, I think it is still in part of the diagnostic algorithm, and the best use would be to use it in where we have an intermediate risk on the combined first trimester screening. So a well-done first trimester nuchal scan combined with the dual marker has a detection rate of 90% for a false positive rate of 5%. Universal adoption of NIPT may not be the most cost-effective model as of now. It is the best screening test, no doubt about it. However, it is also a test of choice. So we do not universally recommend it. We would recommend it to women who have an intermediate risk without any ultrasound markers suggestive of aneuploidy, wherein one would want to go on to straight onto the diagnostic testing. As you outlined in the slide, that women who are at high risk, they may opt for NIPT despite a low risk on the combined first trimester screening.
So I think you have very well summarized, Dr. Chanchal. Now, Dr. Chanchal, it is a common practice. A patient has had a good first trimester combined screen, and when she moves on to the second trimester of the pregnancy, a cord test is also advised. What is your take on this?
So, ma'am, I think whenever we apply a screening test, we are looking at the detection rate or the sensitivity. The combined first trimester screening already has a detection rate of 90%. I would not want to go back to a test which has the lower detection rate and a much higher false positive rate. So if we want to do something better after a combined first trimester screening, the NIPT would be a better option as compared to a quadruple because it has the lowest false positive rate along with the high sensitivity.
Yeah, so I think that practice, everybody needs to be clear, is not a good practice.
It has a very high false
Yeah,
positive.
yeah. And now I hand over to Dr. Gujral to take it further.
Thank you, Sangeeta. And you stop sharing your
Yeah,
screen.
ma'am, I'm sure.
I have my screen. Well, friends, you know, my first question to Dr. Indu Chugh, what are the various pre-eclampsia prediction models and what do you practice in your hospital?
Hello. I think at the outset, I must thank Sangeeta, Asmita, and Dr. Gujral for including me in this panel. Prediction of preeclampsia is nothing new. Even when we were postgraduates 40 years back, we were taught rollover test, and we have come a long way from rollover test to the algorithm developed by Fetal Medicine Foundation. Most of us are using a model which is based on ACOG and NICE guidelines. And it's basically maternal characteristics and high risk factors. They are more or less similar, for barring some differences in the two, in which it has been divided into high risk factors and low risk factors. And if you have one high risk factors or more than one moderate risk factors, that is 2 or more, then that patient has a chance of detection rate is not more than 50%, maybe 40 to 50%. So it's not a very good model, but that's the one which is available to us, Second, a lot of biophysical and biochemical parameters have been studied over last 10 to 15 years, and in which maternal characteristics along with biophysical and biochemical parameters have been combined. I mean, various models have been developed, like maternal characteristics with biophysical parameters, which could be mean arterial pressure and uterine artery pulsatility index. And biochemical parameters which are being used are PLGF and PAPI. And the model which is basically is most researched and also validated in few studies is a multivariate regression model developed by Fetal Medicine Foundation, but it gives you a static one-time risk, like if you do it at 12 weeks, and it includes maternal characteristics, uterine artery pulsatility index, mean arterial pressure, PLGF, and PAPI if you have done. But it will give you one-time risk. And then we have competing risk models, in which you can assess again at 22 to 24 weeks, 32 weeks, and you keep on adding factors in which there are other in which we use FLTN1 and PLGF ratio. This model, that means you have to do PLGF, which is an expensive test. So for low resource setting, this may not be practical in the present scenario. Like PLGF, if possible, do it, and then maybe based on this model, we can pick up, like if we take 10% false positive, then the pickup rate is as high as 90 to 95% of picking up patients who will develop preeclampsia before 34 weeks. For picking up patients who would develop preeclampsia at term, the detection rate, even with this model, is not more than 70%. And what FIGO recommends is a two-stage model for low resource settings, in which maternal characteristics are combined with mean arterial pressure, that is stage 1. And if the patient is screened positive, then you go to stage 2, if the facilities are available. And then there is another contingent screening model also, again recommended by FIGO. And I must talk of gestosis score, which has been developed by for Indian population. Again, this is a very easy, in fact, an app has been developed. There are 25 risk factors or maternal characteristics, which are again mild, moderate, and severe, and they are scored 1, 2, or 3, depending on whether it's high or mild. And anything in this more than 1, that is, it said that patient should be put on low dose aspirin. But problem with this is that this model has still not been validated, and maybe next year or so we'll get that.
Yeah, Dr. Indu, you're quite right. Gestosis has been developed and the person who developed it came to us. But I find the score very, very huge, It's a lot of work on that. But let's see when we validate it in our clinical practice, when we don't have all this, we'll see the results of this. And as you said, as of today, Fetal Medicine Foundation model works best with maternal factors, mean arterial pressure, uterine pulsatility index, and PLGF and PAP-A. 1 in 100 is a positive, and they should be offered aspirin 150 milligram at bedtime from 12 weeks onwards. Now, we know that maternal history is a part of routine antenatal care, and we must learn to take a good history. Mean arterial pressure is a part of routine antenatal care, has not been validated. We just take a quick PP and don't do a mean arterial pressure. There has to be a technique for measuring which will come at, and uterine artery Doppler needs not that much of a training, and it is a part of a first trimester. So we are not bad at that. Now, my next question is, and once we have a close monitoring of blood pressure. Dr. Indu, how do you measure a mean arterial pressure? I've written it on the slide, but just read it out.
Yeah, Dr. Gujral, I fully agree with you. Like, this is one which we should start doing. It's very easy to do, provided we know the right method to do it. It is calculated by measuring the diastolic blood pressure plus difference of systolic and diastolic divided by 3. So that means you have to measure the systolic and diastolic pressure accurately. In this, when the patient comes to your OPD, you ask her to sit for 5 minutes. She should be comfortable, talk to her, make sure that she's relaxed, head straight, legs not crossed, arms at that level of heart, and you should have a proper chair or table on which the patient can rest her arms. And the BP has to be taken in both arms simultaneously. That is very important. And you have to take BP at interval of every 1 minute till you get 2 stable readings. Like I'll explain. Suppose you take first BP 130/90. Next comes as 110/70. Third comes as maybe 112/70. Now the last 2 readings have stabilized, and these 4 readings are taken. You take mean for both arms, left and right separately. And then, like if you have taken systolic, either you can feed into a calculator which will give you mean arterial pressure, or you can do it manually also. All of us have mobile phones with us, so it's very easy. And mean arterial pressure more than 90, that means patient has a chance of developing preeclampsia.
And except that we should use an automated device. We can't have 2 resistors measuring it simultaneously. So yes, the device is automated. And as you said, the difference of 10 between 2 systolics and difference of 6 between 2 diastolics, then take the again till this thing narrows down. As you said it, rest the factors you said. All of us must teach our residents how to take a mean arterial pressure having this device. Now, Dr. Induchuk, you talked a little bit earlier on also. What is the performance of various prediction models for preeclampsia? I'll just do the same.
Yeah. So I'll first talk of a model which is based on maternal characteristics only. And I'll be first talking about the detection rate before 34 weeks, So if we take 10% false positive, based on maternal characteristics and high risk factors, it's only about 50%. And if we add biophysical markers like mean arterial pressure and the uterine artery pulsatility index, it goes up to 75%, 90%. And by addition of biochemical markers, it doesn't perform so good. It's 75%. But if we use the algorithm which has been developed by Fetal Medicine Foundation, the detection rate improves to 95%. And again, I'm talking if we take 10% and the detection of preeclampsia before 34 weeks, if we talk of term, it's only 70%. So I think if we can afford and add, because anyway, we are doing PAP-A, and as has been already said by previous speakers that we should be doing uterine artery PI, mean arterial pressure is not difficult to do, and PAP-A is also there. So if we add PLGF to it, the accuracy is very high. So maybe if possible, we should start using this model.
Yes, thank you, Dr. Indu. This is at a 10% false positive rate. Mean maternal factors 48.3, add on mean arterial pressure goes up to 65, and you add on uterine PI goes up to 88.3. you don't have mean arterial pressure but have PAPA and uterine artery, it is 73.3. This is just to highlight how important a mean arterial pressure is there, and it's a very simple thing to do it and use it more often. And as you go on, the performance improves, and the ones shown in the yellow circles, 90% performance of early onset preeclampsia if you had uterine artery, PIGF, and PAPA. Now, my next question, and of course, like she said, that this is for early onset preeclampsia. There are models to screen again in second trimester, to screen again in third trimester. It's an evolving model to go on to predict late onset preeclampsia, which perhaps is more common than the early onset preeclampsia. Now, Dr. Chanchal, good to have you. My question to you is, if we don't have PIGF, can the mean arterial pressure, part of it shown, PAPA, uterine artery, PI predict the PE with the same efficacy as FMM model? And do we need preeclampsia screening for women with a history of chronic hypertension also? Or you just take them as a high risk? Two questions for you. If you don't have PIGF, can the other factors help us out?
So, ma'am, addition, even if one doesn't have the placental growth factor, as Dr. Indu has already elucidated, adding the mean arterial pressure and the uterine artery PI made the most significant jump in the detection rate. And in that, the validation studies, so the difference, the improvement in detection rate by adding placental growth factor to the baseline screening model of using mean arterial pressure, uterine artery PI, and PAPA, which we are doing anyways, it improved the detection rate by about 6%. So the international journal, the FIGO, as Dr. Indu has already stated, they have proposed a contingent model. So if the placental growth factor is not available, yes, it decreases the detection rate by about 6%, but we can, where it is not available, we must do the other things that we can easily do. As far as women with chronic hypertension, in your first slide, when you showed the risk factors, all across board, that forms a risk factor for women for developing superimposed preeclampsia. Now, in a post hoc analysis of the ESPRI study original, they found that the one category in which aspirin did not work as effectively as other women were the ones with chronic hypertension. But that is the post hoc analysis. But as of now, I think both ACOG as well as RCOG, they all agree that women with chronic hypertension should be put on aspirin. Dose is debatable. The ACOG still sticks to the 75 to 80. So we're not sure whether it really helps those women with chronic hypertension or not.
Thank you, Dr. Chanchal. Now, this article I came across where, it is opposite of what we shown you in the slide, that this is from China, a very large study, very recent study, where they call it a triple marker model containing mean arterial pressure, uterine P and PAPA. They have the false positive rate and prediction is written on the slide. Replacing PAPA with PIGF or adding PIGF did not improve outcome, which means to say, are we saying that PIGF is not good enough? This article is very recent. Because it's from China, we may not like to believe it, but there's another article in the same journal, the next article. This is from the NHS, retrospective data on the women who delivered, aborted, etc. And the things are done. And they again say that PIGF or PAPA in a routine first trimester combined screening based on maternal characteristic, blood pressure, uterine artery Doppler does not make a clinical significance to the detection of PE and ST. So I don't know which one to believe, that's the best or this is the best, but what we want to give a message that if you don't have PIGF, don't worry, PAPA can be added to uterine and mean arterial pressure to have a good detection rate.
There's a paper from Lady Harding, Manisha's paper, in which they thought that PLGF did improve the detection rate and performed as well in the Indian population.
The FMM model has produced till date, yes. And this is only 2 articles from the White Journal. I up, and I don't know whether to react to it.
Gujral, you're not very audible again.
I said I didn't know how to react to this article. The first article was from China, so I thought maybe, And the second one is from the same data which has been stored. So we have to really see now
Yeah.
whether.
Yes, ma'am. Yes, and then just to complete the list of things and something which is available from our own people. So I thought
that's what this. A marginal improvement may still be there. This is just individual study. That's all. And secondly, yes, we should use it for women who have a chronic hypertension. We do agree with that. And as you said, again there was one article very recent which I couldn't put it up, that the women who do not respond well, to the prediction model doesn't work, is one is chronic hypertension, one is a risk of between less than 150 as against 150 to 100, and one is the PLGF level is less than 0.729 or something. So these are three issues. If you're doing the levels, moms are there. They are the women who will not respond to aspirin. Nice. So moving on to our next question for Ranjana, that's SGA screening. We know part of SGA, I would say majority of SGA is following the preeclampsia or the hypertension, but there are many also who do not have the maternal disorder. Can we screen those SGAs in the first trimester by some methods? Dr. Ranjana?
So again, we would see the maternal characteristics first. So all the risk factors which were mentioned for preeclampsia, because they share the common pathology, fetal growth restriction and preeclampsia. So all those characteristics should be seen. And then if they have a history of small baby in the past, in the previous pregnancy, and then so I didn't get the question very correct. I didn't hear you very well.
SGA without preeclampsia. Preeclampsia we have screened.
Yeah.
So you rightly said so. SGAs can be predicted by maternal characteristics, some biophysical biomarkers.
Screening for SGA, right?
SGA, yeah, at the first trimester, you said it all. We just have to monitor and give them prophylactic aspirin.
Yeah, and then again, the mean arterial pressure and
absolutely the same, actually, practically same.
Yeah.
Now, macrosomia screening, Dr. Aruna. Macrosomia screening in first trimester. Are you there?
Yes, I'm there.
So please respond.
Yeah, so this is a new thing has come. We can screen for macrosomia. So there are physical things and there are biomarkers. Nothing has been validated very much, but still we need to take a maternal history of diabetes and history of macrosomia in previous pregnancy, obesity. These are very important markers, and also the ultrasound gradually in whole of the pregnancy. Besides this, it has been seen that we can test via a few of the biomarkers, and out of these biomarkers, people have said that we can use triglyceride and HDL levels, especially in the third trimester, that it is very much predictive in all type of pregnancies. Adiponectin level, that is very important. And FMF has given a model where they have considered their body mass index, history of diabetes, PAPE and free beta HCG, which they have predicted. But nowadays, few of the studies have shown that the accuracy of 1,5 and hydroglucitol has very much accuracy or prediction of the macrosomia in the pregnancies. So these all are still for a research purpose. We don't have any biomarker which we can say that yes, this biomarker you do and we can predict the this thing macrosomia. So we have to trust on the trust on the history, obesity, body mass index, and diabetes. That is the most important factors.
Pre-pregnancy, obesity, type 2 diabetes, or gestational occurring. These are women who are going to have macrosomia. Rest all is just for a question or a research purpose. Similarly, miscarriage and stillbirth, Indu. Short one, quick answer, please.
Yeah, we know a number of models are being developed, none of which has been validated, which include maternal risk factors along with NT, uterine artery PI, beta HCG, PAPE, and also ductus venosus PI. Various permutation combinations are being tested, but the problem with these models is they perform better for stillbirths which are secondary to inadequate placentation, and not for stillbirths which are due to other causes, And that too, the detection rate is not very high. So I wouldn't say the stage is there that we can predict.
Agree with you. So just to complete the thought, we have the early pregnancy monitoring preeclampsias, which lead to most of these stillbirths, but still, ductus venosus in reverse way, they are the ones who perhaps may predict a stillbirth, to some extent, but yes, we do not have a model. We move on to the next question. Sangeeta, share your screen, please.
Yes, ma'am. Thank you so much.
All right.
So taking forward, we were talking about cervical length in the scan, which we had done at 12 weeks. So Dr. Ranjana, what is your take on doing a cervical length on ultrasonography? Should it be done universally? I will come to every step one by one.
Cervical length is measured to predict the risk of preterm labor. So if we restrict ourselves to only history suggested cervical length measurement, then we will be able to pick up only 15% of, or we want to treat them, then prevent only 15% of preterm births, because 85% of preterm births which happen from very low risk population. And this constitutes the major part of the pregnant women population, are almost 97%. So if we actually want to, detect the risk of preterm labor in the general population, then any test that only targets the high risk group, then we will be, addressing only the 15% of the problem, and we'll be missing the majority of them. So I think if your resources are, it all comes down to the resources. So if you can afford, then it's better to do a universal cervical screening. But if you cannot, then, all women who have high risk, they should be screened, definitely, and sequential screening.
There is divided evidence on the issue of universal screening with cervical length on ultrasonography. The FIGO recommends it. The ACOG says it's a level B evidence, and RANSCOS also says one can consider. However, the Society of Maternal Fetal Medicine, RCOG, SOG, and even FOXY has not mandated. But I agree with you. We are the biggest contributors of preterm birth to the world. And I think we need to create local evidence before we say it should be done or not. And the second issue would be, are our resources going to permit it? Now, Dr. Ranjana, the next question is, should it be measured in the first trimester?
Again, if you have expertise, then why not? I think the best will be to measure around 12 weeks when you do your first trimester screening. And but if you are not doing the first trimester screening, then the best time is to do it at the anomalies scanning. So it will be around between 19 to 24 weeks. So that should be the time.
However, ma'am, the evidence so far does not recommend any screening of preterm birth in the first trimester, even if the woman is with previous preterm delivery. There is a lot of work going on it, but no evidence has emerged so far. If we opt for universal screening, the ideal time is to couple it with the anomaly scan. It should be a single time examination during the anomaly scan. However, if we are going to target the high risk population, particularly the women with previous preterm, it should begin at 16 weeks, should be a serial monitoring every 1 to 4 weekly till 24 weeks of gestation. So I come to case number 2, which is a case of previous cesarean section at 29 years woman, gravida 4, para 1, 2 abortions, 13 weeks pregnancy, a previous cesarean section, and 2 MTPs by medical method. So Dr. Angela, what additional risk assessment can be done in these women?
So as we have, already discussed with the 12-week scan, all these things can be done, including, plus we look into the placenta, where the placenta is. That's another very important thing. And if she is a previous cesarean, then we have to look into it, whether it's a scar, that there should not be any pregnancy in the scar. And we have already discussed detailed anamnese scan, the Doppler, the preeclampsia screening and everything.
Yeah, so cesarean scar pregnancy and for any evidence suggestive of a morbidly adherent placenta. So Dr. Angela, can you just talk of implications of a placenta covering the os in the first trimester scan with respect to a woman who's not having a previous cesarean section and a woman who has a previous cesarean section?
This is a clear-cut placenta covering the os. So there's another term, which is the placenta reaching up to the os. Many radiologists, that it's a low-lying, they also report. So there is a difference between these two. So first, let's see what is the placenta covering the os. So if there's a placenta covering the os, the most of the chances are that this is going to persist as a placenta previa in the later half of the pregnancy. So one needs to do a close follow-up on that. If it's a previous cesarean section, so it's very important to look for placenta accreta spectrum even at that stage. You need to look into the details of the placenta, the space between the placenta and the myometrium, any infiltration, any lacuna, any turbulence of the blood flow. You can put a Doppler also, and if you are suspicious of it, then it's very important that you have a close follow-up and plan the patient delivery in a tertiary care center where the ICU and the blood is available, so that you can help this patient to move to a tertiary care center as early as possible in her pregnancy.
Yeah, so what the evidence has shown is that a woman who has a previous cesarean section, and if the placenta covers the os even in the first trimester, there is a very high likelihood that about 75% of these women would have a morbidly adherent placenta. This is one of the studies. So probably we need to monitor these women very closely.
Very closely. And, when they report it as there's a low-lying placenta reaching up to the os, not covering it, 95% of them, they move up, and only 5% of them, they stay at a lower place.
Yeah, we want to re-emphasize that we are talking of a placenta covering the os in the first trimester. We are just restricting ourselves through a first trimester discussion. Dr. Angela, now there is another issue when a gestation sac is seen in the lower uterine pole. With respect to a patient who's not a previous scar and another one who is with a previous scar. So what is?
Whenever a patient who comes with an ultrasound diagnosis of a gestational sac in the lower part, so what it comes in your mind is, it's always important to take a history and see whether it's a previous cesarean or not a previous cesarean. If it's a previous cesarean, then you have to look for a scar ectopic. Or second is a low-lying placenta, which will become maybe morbidly adherent in the future if she has a cesarean, So this also needs to be keep in mind. And it's a scar ectopic. If it's a pregnancy in the scar, then it's growing either inside in the scar going towards the myometrium, and there is a thinning of the myometrium, which is between 1 and 3 mm, or a part is bulging into the uterine cavity. But if it's a low-lying placenta, or it means if the future it's a cervico-isthmic junction, then the myometrium thickness is more than 6 millimeter. That differentiates between a scar ectopic and a low-lying, low sac. Another two important thing which comes with a low sac is whether this patient is having a miscarriage. That comes on the follow-up, or the ultrasound, if there is sliding sign is positive, or there is no peritophoblastic flow, then this patient will miscarry. But if there is no sliding sign and there is a good Doppler flow, and there is a pregnancy inside the cervix, then we should keep it in mind that this is a cervical pregnancy. So low sac has 4 differential diagnoses. One, patient is miscarrying, or is a cervical pregnancy, or in the future might become a placenta accreta spectrum, or it's a scar ectopic. So follow-up is must. It's important to counsel a patient and keep her under supervision.
Yeah, thank you so much. So I think my idea of bringing forth this discussion was that I think how valid the cesarean section audit is, which is being done by the NARCHI team. With so many sections coming up, I think we all will be seeing these kind of patients more often. And so we
have seen in our practice that cases topic have increased.
It much more than what we used to see a decade back. And the people who will be practicing a decade later should be prepared for this kind of a havoc. Yeah, now we come to the end of this panel discussion, and I think no panel discussion will be complete till we talk about a twin pregnancy. She's a 30 years female, a second gravida, para 1A1, gestational age 13 weeks, spontaneously conceived, and previously had a low risk pregnancy, full-term normal vaginal delivery. So Dr. Indu, what would you look for in an ultrasound for twins?
Dr. Sangeeta, first I'll ensure that they are twins and not multiple pregnancy of high orders.
Very good, yeah.
Yeah. And second, I'll ensure that both are viable. I mean, I look for viability. Next, I do pregnancy dating by looking at the CRL. And CRL of bigger CRL is used for dating the pregnancy. The most important thing which we must look is chorionicity, because that's how we, based on chorionicity, we are going to manage the patient. So if I see two separate placentas, that means it's a dichorionic. If I can't make out whether they are two separate placentas, then I look for the sign, lambda sign or T sign. Lambda sign, in which you see the chorionic tissue going into the dividing membrane, that is suggestive of dichorionic. And if you see T sign, that is monochorionic. And next, I should label. I should not label it as A or B, 1 or 2. It should be right and left, upper and lower. And at the same time, I'll be doing screening for aneuploidies. And in screening for aneuploidies, like for monochorionic, the risk is assigned to the pregnancy. Like for both fetuses, is the same risk. For dichorionicity, you measure the risk separately for both fetuses. And screening for structural abnormalities, maybe we can pick up early signs of discordant twins at this stage if I find difference in the CRL.
Yeah, thank you so much. I think that sums it well. And Dr. Chanchal, what cases would you like to be referred to you after the first trimester scan? Dr. Chanchal, I think,
yes, all the monochorionic twins, I think they would be better managed in a fetal medicine unit because of the detailed examination and interpretation of the Dopplers, especially.
Yes.
Any twin which is discordant for anomalies, they can be referred for a reduction, selective reduction. Discordant CRLs, or if there is a differential high risk aneuploidy, any high risk that warrants further intervention in terms of invasive procedures, that they should be referred.
Yeah, so I think,
and the pregnancy with higher orders where the twin has one of the pregnancy has spontaneous disappeared. I think even those should be referred to a fetal medicine specialist, where we can't do any kind of NIPT screening or a biochemical screening.
Yeah. So
I feel even those should be looked into it.
So with that, we come to the end of this panel. And the few messages which I would like to give at the end are that we should tailor the pyramid to our own priorities. That's very important. A Brazilian study has come up which had, preferred to screen for preeclampsia than for aneuploidies. And we also need to, relook into ourselves. Absolutely. The maternal characteristics and history coupled with biophysical markers, biochemistry do define the risk in many disorders, but where they don't, history and maternal characteristics again become the primary mode of screening. Accurate gestational age determination is indispensable and best done in the first trimester. Preeclampsia, hemoglobinopathies, and gestational diabetes mellitus, it's the time we wage a war against them. These should be our priorities. It took us a decade or maybe 15 years to learn aneuploidy screening, but we don't have so much time. We really need to be very quick, fast in learning these. Previous sections has become a matter of grave concern, but however, there is scarce data to look for it in the first trimester. But it is good to know keeping in mind what the future holds for us. It's the writing on the wall, and multiple pregnancies do require a very critical evaluation right in the first trimester. It's a very important, it's a very critical evaluation point here. And with this, I would like Dr. Gujral also to say a few words.
Yeah, Sangeeta, you said it all. My only thing is that, yes, we should tailor it as per our, facilities available, but 2, 3, 4, 5 recognized centers. And today, city of Delhi has many fetal medicine specialists. So the practitioners and even maybe the public health people where their patients can afford should send to centers which can do a good first trimester scan. Compromise on anything else, but a good first trimester scan from recognized centers. Like you showed such a bad image. I mean, what does one comment upon that image when you get a screen positive or a negative?
But that's the ground reality.
That's the ground reality. So somewhere you should, at least as we in practice don't have a problem, but I can understand public health, such a lot of load you have, it's not possible. But what can we do is that you have good centers in public health like yours, where you should, patient should be sent to you, or even Lady Harding, or every medical college has it. So screen, and send to the fetal medicine person so that we can pick up a real high risk and go forward. That's my take at first trimester. And thank you, panelists. You all been wonderful. Good learning from you all.
Yeah.
Thanks, Dr. Sangeeta and Dr. Gujral, for beautifully covering all the aspects of first trimester screening.
So I thank all the panelists, and I thank Dr. Gujral for guiding me through this panel. With that, we come to end of this panel and we close this session. Thank you so much.
Thank you, Sangeeta. Thank you, Dr. Gujral.
Thank you, everyone.
Moderated by Dr. Manjupuri ma'am and Dr. Manisha. Dr. Manjupuri, as we all know, one of the most celebrated teachers. Ma'am is ex-head and director professor, Department of Obstetrics and Gynae, Lady Harding Medical College. Ma'am is chairperson of Safe Motherhood Committee, AOGD, and also now the incoming president of NARCHI Delhi. Dr. Manisha Kumar, ma'am is Director Professor, Department of Obstetrics and Gynecology, Lady Harding Medical College, New Delhi. Also in charge of Fetal Medicine and Genetic Lab, LHMC, and has many research projects and publications in her name. Welcome. I would like to invite the moderators to commence the panel discussion.
Before I go on with the panel, I've introduced my esteemed panelists. So first, we have Dr. Jyoti. Dr. Jyoti Bhaskar is a clinical director of Apollo Cradle Hospital, Indrapuram, Delhi. And I sincerely think that her inputs would be very welcome in the cases that we have. Dr. Madhvi Gupta. Dr. Madhvi is director professor in Maulana Azad Medical College. And her experience at a public hospital also will be a great help in this finding out what we are trying to achieve here in this panel. And then we have Dr. Rachna Agarwal. She is professor at UCMS NGTB Hospital, and she also is from a public hospital where we get these patients who come late. So we welcome Dr. Rachna. And next we have 3 fetal medicine specialists, Dr. Reema Bhatt, who was previously in Army Hospital, and now she is a senior fetal medicine consultant in Cloud9 Hospital. And we have Dr. Sumitra, who is a professor in and senior specialist in Safdarjung Hospital, and she's in charge of the fetal medicine over there. And we have Dr. Jaya Chawla, who is associate professor at RML Hospital. So I welcome all the panelists, and I would like Dr. Manjupuri to give some introduction, and then we will begin with the cases.
Yes, so thank you, Manisha, and thank you, Team NARCHI, for having us here. After a very interesting panel discussion on Catch Them Early Comprehensive First Trimester Care, so we will now move on to another fancy panel, which is Miss the Boat, Late Bookers. So if we look at it, as the name indicates, so all that we discussed in the previous panel, if we do not get an opportunity to do that for our patients. So we do have patients coming with different problems. And so our panel is going to highlight those kind of case scenarios. Interestingly, whatever, their final slide listed, all our cases are similar to that. So we both have separately made the panels, both teams, but then we all understand that the cases are the same. So the problems are common and everything else is similar. So basically, we will be looking at certain case scenarios wherein the patients have reported to us late. In our own hospital, which is a public hospital, we have about 40 to 50% of the patients which are unbooked. So they come to us in second or third, unbooked means those are the percentage which would come to us in labor. 40-50% would be without any kind of antenatal care, and there would be only 10 to 15% women get registered with us in the first trimester. So that means it is a huge lost opportunity. And it is not only this, the other aspect which we feel is that those who have had antenatal care have not have not done the screening or started the interventions which could have altered the outcome of the pregnancies with which the patients come to us. So it seems a lack of sensitization of what we can do, and of course for the patients who are not able to get themselves registered for various reasons. So with this background, I'll now pass it on to Dr. Manisha to take you forward through the panel discussion.
So the antenatal care provides healthcare services to antenatal women to ensure the best possible pregnancy outcome to mother and the baby. So basically, the care includes screening for the pregnancy problem, as we have seen in the last panel also, assessment of pregnancy risk, provision of information to the pregnant woman, and support to make pregnancy and birth a positive life experience. Early ANC contributes towards improved pregnancy outcomes. So I was just looking through the literature to see what the literature says about late bookers. And I found there were a few interesting articles. And in one of them, which was from Africa, they had mentioned that they also had nearly 52% cases where the ANC is late. And they have also looked into the reasons. And they found that being a housewife, being self-employed, traveling expenses when the hospital is far, poor knowledge about ANC, which was the most important factor among all, and unplanned pregnancy was also one of the major factors. Unfortunately, I couldn't find any study in India, and it is a good opportunity to do study on this also. So we will begin with the common ones, so we will begin with the first case, which is a patient who was 32-year-old, G2P1L1A0, presented at 36 weeks of gestation with pain abdomen and bleeding per vaginum for 1 day. There was loss of fetal movement since 8 hours. Her BP at admission was 160 by 100 millimeter of mercury. Pedal edema was present. She received tetanus toxoid injection at local dispensary, but no physical antenatal checkup was done. And she was diagnosed as having placental abruption when we examined her clinically. And she was a case of FGR also with intrauterine death, which was confirmed on ultrasound. In her obstetric history, first pregnancy was 2 years back, which was an unbooked pregnancy again. And there was history of swelling of feet before delivery for 1 week. And she had a full-term vaginal delivery at home, which is a baby girl, alive and healthy, but she said that she was of low birth weight. So I would like to ask Dr. Jyoti, ma'am, could this adverse event be averted in this patient?
Thank you so much, Dr. Manisha and NARCHI, for having me here. Yes, this is indeed an extremely bad and most adverse event that any woman would like to go through. Yes, this could have been averted had we seen this particular patient much earlier, that I would say the first trimester itself. Because at that time, we had the opportunity to take a detailed history, identify her high-risk factors. And as we have already talked about in the previous panel, we had all the opportunities to carry out the screening, to look for the prediction of PET, to look for the prediction of FGR. And if we did have that opportunity, we could have monitored her, we could have predicted, we could have prevented, and we could have monitored her very well.
So how would you have managed this patient had she reported early in pregnancy? It will be in what you do generally at your hospital, your experience.
So when such a particular patient would come to us early in the pregnancy, first of all, we'd like to take a detailed history of a past pregnancy. That's extremely important. This patient was unbooked, delivered at home, so she will not be able to say much to her. But 2 pointers we do have in that the baby was an FGR and she had pedal edema. That's something we would suggest or think retrospectively that she did have PET. So apart from taking a detailed history to identify the various high-risk factors that we can have, then we of course are going to see BMI, because BMI is also another important predictor for the baby woman developing FGR much later on. Important at this time is also, as we've already talked about the predictions of PET in the later life to develop preterm PET is concerned. So we need to do the MAP, which can be done at low resource settings. We need to convince the patient, if it is in a high resource settings, or if we do have the resources, to undergo the 11 to 13 week scan, which apart from the aneuploidy screening, will also act for us for predicting her risk of having PET later on, especially the preterm PET, as well as developing FGR much later. So we've already talked about these in detail. So if we do not have very good resource settings, then at least a risk factors plus MAP. If we do have the facilities, please, we will add on to that a uterine artery Doppler. That's a PI of the uterine artery can be added, and PLGF. If you're doing a combined test, then of course PAPI. But I think we've already discussed that quite in detail. Yes. So this is how I would manage this patient. So, and later, of course, is the monitoring of the patient is very important, that we will carry on later, because we know that there's an FGR. So we're not going to leave the early anomaly scan and thereafter 28 weeks. And then every 4 weekly, we're going to get a growth scan done and a regular monitoring for the blood pressure and for the signs of developing PET.
Yes, very rightly said. I would just like to emphasize that in preeclampsia screening, the integration is the key. So more markers you add, you increase the detection rate. So we should always try and take whatever we have, and should not think that if we don't have PLGF, we'll do nothing. So this is here. Do you use FMF software in your practice, ma'am?
Yes, definitely, because all the scans that I do send is sent to the fetal medicine people. So they are using the MFF model to do it. And in case the patient just refuses to pay up for this particular, because it's a little expensive as compared to there, then these particular calculators are freely available. At least I use it with the risk factors, with the uterine artery PI, as well as an MAP at least.
Yeah. So the good thing about this software is that it's free and you can use whatever you want. Like if you have only maternal factors, you can use that and it will give the risk. If you have a map, you can put that and it will give you the risk. So it is not necessarily that you'll have everything and then you will put, so it will give you the risk depending upon whatever you have. So we must encourage use of this more and more. Now, what specific postnatal advice would you give to this patient, since she has had already a loss now?
So the postnatal period is extremely important. Now, there are certain things about the postnatal period is that she's hypertensive. So we need to monitor her blood pressure, especially when she's in the hospital, to carry out every 4 to 6 hours to be seen the blood pressure. Then when she's going to be discharged from the hospital, 2 things are very important that we're going to tell. First of all, the follow-up plan, that she needs to come back to see us after 1 week and then at the 6 weeks postnatal visit. We need to have a look at the antihypertensives that we're going to send her on. If she has been, it's preferable to give over here the amlodipine can be changed to the patient, and she's given about that and told her about the importance of taking these particular antihypertensives. And then we try to review it again at 1 week, and then we review it again at 6 weeks when she comes to us at the postnatal period. Also over here is the contraception. We can sensitize her at this particular time at discharge about the contraception, but when she comes to us at the 6 weeks visit, there we need to really tell her that she needs at least a gap of 2 years before she conceives, so as to improve the pregnancy outcome subsequently. At the 6 weeks postnatal visit, other things that are very important is to tell her about the future risks, since she's had a PET at this time. So for the future risk, the recurrence in the next pregnancy is to the tune of 1:4 to 1:5. Because of the PET this time, she has increased risk of developing cardiovascular diseases, stroke, hypertension, and thus we need to specify about the lifestyle modifications. That is, if she is taking alcohol, that has to be stopped. Cocaine use has to be prevented, although we are not expecting this, but yes, definitely we should be aware about these 2 factors, a healthy weight and a healthy diet that she has to be done. So that in future, this particular recurrence of these particular factors has been found to be much less. Also very important over here also is to consider about the vitamin D, that is calcium supplementation that needs to be given to it. So, yeah. And also I would like to say that at 6 weeks, we also need to find out other causes. See, this particular patient has had two, and she's had an excessive adverse event like an abruption. So yes, we do agree that PET must be most commonly responsible because of the uteroplacental insufficiency. But in the back of our mind, we should also think about APLA, that is she a patient of APLA? Does she have any secondary causes of hypertension? So at the 6 weeks visit, it would be worthwhile to revisit her, take her history again, and probably offer her these tests.
So thank you, Jyoti, for that input. So basically, I personally feel from this case, there are two take-home messages. The first one is that the fifth pillar, which Dr. Shakun had said, a detailed history is most important, and that will give you a clue in categorizing as to which patient is high risk. So I think in this patient, we had that clue of the baby being, maybe possibly a FGR, and with that swelling feet, maybe possibly she might have had, preeclampsia. And the second important thing is that it is not essential to have all these investigations available at every level of care, primary, secondary, tertiary, whatever facilities are there. I think we should try and identify those patients who are at risk of preeclampsia and put them on preventive therapy. Aspirin starting 150 milligram, starting from 12 weeks onwards, and continue. So in this patient, it seems she had a tetanus toxoid. So it actually tells us how poor the quality of antenatal care is. It is not only at peripheral centers. Let me be very candid in saying that it is poor at our own big hospitals as well. So patients do get missed. So I think CMEs like this are very, very important to tell people as to what is the power of first trimester, screening. If the patient, with clinical. So it is not that, I'm saying there are a lot of things which we can pick up just by our routine investigations and routine detailed history. Thank you.
Right. So thank you, Dr. Jyoti. We'll move on to the next case. So case 2 is a 25-year-old primary gravida. She presents to the antenatal clinic at 28 weeks gestation with easy fatigability. Her point of care investigation shows her HB to be 7.5 grams per deciliter. During the workup of anemia, she was diagnosed as a case of beta thalassemia trait. Her partner was screened for thalassemia. So Dr. Jaya, can you tell us how will we counsel and manage this patient if her partner was found normal on screening?
Good afternoon, everyone. Thank you for having me here for a very, very stimulating panel discussion. Ma'am, the first things that I notice in this case are that the hemoglobin is 7.5 grams per deciliter. The period of gestation is 28 weeks, and the patient is symptomatic. She has a complaint of easy fatigability, which has led us to the final diagnosis of thalassemia minor. So in case the partner turns out to be normal, the first thing that we have to highlight here is that it's the most common inherited single gene disorder, and the mode of inheritance here is autosomal recessive. So when the partner is normal, it essentially means that the partner has been screened using an HPLC, and the carrier state for the partner has been ruled out. And in that end, the chances for the offspring to get a carrier state are going to be 50%, whereas the other 50% of the progeny is essentially going to be absolutely normal in terms of their genetic diagnosis of thalassemia minor is concerned. Since both these possibilities do not have any material implications for the progeny, you would just reassure the family that all is going to be fine insofar as fetal genetic transmission of this disease is concerned, and they can carry on with their pregnancy like always. The matter of concern here would be the maternal concern of 7.5 gram HB, which needs to be dealt with further.
Yes. So what, would you like to give her blood transfusion or not at this state of the HB 7.5, and she's symptomatic also?
Ma'am, most of the literature concerning thalassemia has focused on thalassemia major and thalassemia intermediate. Here, I would like to suggest that we are talking of a case of thalassemia minor. So we have relatively few choices insofar as offering blood is concerned. And one of them happens to be when the patient is symptomatic, as in this case. The other instances where we might have to think of giving blood would be whether she has worsening anemia or she has events of hemorrhage which are threatening her condition, or we are close to the time of birth wherein we have to plan for a delivery or a cesarean birth, whatever the case be. In all such circumstances, we have to keep a hemoglobin at least above 8. I would also like to emphasize here that most of these patients are non-transfusion dependent, since we're talking of cases who've been picked up later in pregnancy, because all cases of thalassemia major and otherwise are going to be picked up early on in their lives. And therefore, for non-transfusion dependent thalassemics, the cutoff to be maintained is 8 grams per deciliter. And yes, I would like to give blood in this particular instance because the patient has come to us with a symptomatic picture.
Yeah. And what about iron studies? Would you like to give her iron, and what you will like? What is the benefit of doing an iron study in this case?
So, ma'am, when we come to a blood picture of hypochromic microcytic anemia, that is a first red flag in the diagnosis of thalassemia minor. So we have two differentials when we come across that blood picture, and here it is MCV less than 80 femtoliters and an MCH less than 27. That essentially help us suspect hypochromic microcytic anemia, and the workup of which would entail either iron deficiency anemia or thalassemia minor. It is important to differentiate between these two because in one instance, iron is going to be beneficial for her, and in the other instance, it could be controversial. We also come across cases who have superimposed iron deficiency anemia over a baseline thalassemia minor. In our practices, it is not very unusual to find those cases. So it is important to perform iron studies in that case to figure out where we stand with the management of, in terms of the iron supplementation. For the first instance, most of these patients come to us already on iron. So we are supposed to stop the iron supplementation for about, say, 3 to 7 days and then offer iron studies in order to not have any impact on the iron supplementation that the patient was already on. After that, a picture of iron deficiency would look like a low serum iron levels, iron binding capacity would be increased, and saturation of transferrin would be low, somewhere to the tune of 20% or so. However, and ferritin stores are going to be less, something to the tune of 15 nanograms per ml. However, in case of a thalassemia minor pregnancy, we would, in addition to having a microcytic hypochromic blood picture, we would have iron stores which would not be deficient. So ferritin would be more than 30. Sometimes we see figures like 250, 267 in our clinical practice. And all of these women who are not iron deficient would not require iron supplementation at the point of care when we are doing these tests. There are a couple of important things to assess here. One of these is that these patients who are iron sufficient at the point of testing could later become iron deficient as the pregnancy advances because of ineffective erythropoiesis in these cases, along with dilutional anemia, which is going to be at its peak somewhere at 34 weeks. So at this point of time, even if we find the patient to be iron sufficient and we withhold iron for this reason, we would have to redo these testing somewhere at a period of 4 to 6 weeks later and reassess her need for iron. And if there's a ferritin store which is deficient and there is a combined picture of iron deficiency along with beta thalassemia minor, then these patients would become candidates for iron therapy, in which case we normally give them 200 milligrams 2 times a day or something, because the iron absorption is not increased categorically, as is the case with iron deficient women. So we do not have any advantages giving them 3 times a day doses. And we normally stick to only once or twice a daily dosing if we find them to be iron deficient.
Yeah, and cause any adverse outcome in the fetus also, like
yes.
The patient is chronically anemic.
Yes, ma'am, studies have counted that because there is a general hypoxia, like state maternal hypoxia owing to anemia, this results in fetal growth restriction in many of these cases, and also there's consequent oligohydramnios. Correspondingly, incidence of fetal distress and incidence of cesarean section is increased in many of these cases. And therefore, it is important to offer fetal surveillance in addition to maternal surveillance to these women. So 4 weekly studies of biometry, LycoRed and Dopplers, as the case may be, should be instituted starting 24 weeks of gestation, so that early onset as well as late onset varieties both can be picked up. In addition to that, when we offer transfusion to these women, it is very important to realize the concept of cross-matching for not just the major groups, but also the minor antigens. Because some of them become alloimmunized in the course of their transfusions, and that has a potential threat for the fetus in terms of fetal anemia. And therefore, a second component of fetal surveillance then would be middle cerebral artery peak systolic velocity.
Yes. So you have already answered this, that because she is, has come late in pregnancy, if the husband is trait, we would probably not offer and just tell them that what are the consequences if the husband is trait. What would you advise in the next pregnancy?
In the next pregnancy, we would be a little wiser, and the patient would have already understood the importance of preconceptional counseling. So we would invite her for another session prior to a planned pregnancy, where we would like to investigate both the partners in terms of the mutation analysis. There are numerous mutations associated with thalassemia minor. However, it is 5 most important mutations that are very common in the ethnic population that we see. And therefore, picking those mutations up is very important, because once we have identified the cause, the genetic cause, the genetic basis of the thalassemia in both the partners, then we have to look at the similar mutations in the baby. And that would be done by offering a chorionic villus sampling between 11 to 13 weeks. The fetus could be homozygous or compound heterozygous. And in those cases, which are 25% of the instances, the fetus is likely to be suffering from thalassemia major. And therefore, a termination of pregnancy can be offered. However, in another 50% of cases, the baby would only be a carrier like the parents. And in such cases, the pregnancy can continue further without any major implications for the baby. Another 25% of cases, there would be absolutely normal fetus, and therefore they can also continue as normal.
Thank you, Jaya, for this. And I think the take-home messages here would be, one is that, whether the, right in the first visit, it is important that the patient is screened for, instead of hemoglobin, we do a CBC and we look at MCH and MCV. And based on that, we can, and Menzer index, that is, when you take RBC count also into consideration, that you can suspect or find out which are the patients who are likely to have thalassemia, beta thalassemia. So that is one thing. So instead of doing only hemoglobin, please do a CBC. So that is what is important. The second thing is that if a patient is found to be a carrier of thalassemia or thalassemia trait, then please do test the husband, okay, the partner for that. And in case he is normal, then it is okay. Then we need not do anything extra, except that if the patient is iron deficient, we need to supplement iron to keep her hemoglobin at normal level. It will stay below the normal, but then as high as possible, she can go up. Some will go up till 9, some will go up to 10. So that is okay. Then in case the husband is also a carrier, then of course we must remember that we have to offer them prenatal diagnosis in next pregnancy, because there is 25% chance that she might give birth to a baby which is thal major. So that is something which is very, very important. Thank you.
Okay. So now we'll move on to our third case. So our third case is a 32-year-old primary gravida. She had her first antenatal visit at 18 weeks and was advised quadruple test and an anomaly scan. She got the ultrasound done at 22 weeks, and which showed a single live fetus of 22 weeks with an echogenic cardiac focus in the left ventricle and bilateral renal pylectasis of 5 mm in the right and 7 mm in the left kidney. LycoRed was adequate, placenta was anterior and not low-lying. So, so this is the pylectasis that was seen. So may I ask Dr. Reva, what are the implications of these ultrasound findings and how would you counsel her?
First of all, thank you, Dr. Nanju and Dr. Manisha, and for having me over. We understand that in today's era, with prenatal screening, genetic sonogram does not have too much of relevance. But when we pick up these soft markers like this echogenic intracardiac focus and pylectasis, by say they are very low likelihood ratio. But in this particular patient, there has been no prenatal biochemical screening done. We don't have the combined first trimester screening, and therefore we are not able to attribute a aneuploidy risk to this patient. At this point of time, these markers become relevant, and therefore the likelihood ratio, as you've already shown here, is for a echogenic intracardiac focus is about 0.95, which is less than 1, and mild pylectus is also 1. But the adjusted risk in terms of these biomarkers becomes higher for this particular pregnancy when we recalculate the risk. And therefore, this is the patient where we would like to convince them to go ahead at least with an invasive testing, because we are already at 22 weeks. Even though abortion limit has gone up to 24 weeks, by the time we have the results of NIPT, it would be too late to offer termination if the pregnancy is affected. But of course, it entirely depends on the patient. If they're not willing for an invasive testing, NIPT is an option. But definitely, the ACOG and the Society of Maternal Fetal Medicine do recommend that if the patient is not affording for an NIPT and you get these markers, a quadruple test can be offered. But we also need to counsel the patient. The quadruple test has a sensitivity of only about 70% to pick up down. So we are going down, and we may not be very clear in offering the best evaluation as far as aneuploidy screening with a quadruple. So here, invasive testing would be the best approach forward. And we also need to counsel that it's not just the aneuploidy, echogenic focus, 30% of the Asian population have it. They really don't have to get a fetal echocardiography done for that. As far as pylectasis goes, with a size of about 7 millimeters, we need to watch for growth. I mean, at 32 weeks, we would prefer to repeat the ultrasound to see if there's a progression of the pylectasis, and anything more than 10 millimeters needs a postnatal evaluation for the fetus.
Yes, so I'll just, so you have very rightly said that having an isolated marker is different from having a 2 markers. So if you have a 2 marker, you can either use this, the formula that was given very early, like 2013, it came out with a Nicoletis group. So we can use this formula, or there are softwares that can use these formulas. So when there are 2 markers, then we use LR plus and LR minus, and then we calculate. So generally, when there are 2 markers, the risk becomes more, as in this case, it became 1 in 83. From 1 in 600. So we can advise them invasive testing. But if there is an isolated marker, that happens mostly, like patient comes with ECF at 18 weeks, and what should we do?
So if at 18 weeks, yeah.
So 18 weeks, 20 weeks, if she comes with 1 marker only, then
we really don't have to. If you have a combined first trimester screening available and it's just 1 isolated marker at 18 weeks, even a quadruple test could be good enough for the patient if there's no combined first trimester screening available. And if that is available, it really doesn't alter our a priori risk, because the likelihood ratio is low, and it really will not change our risk for downs in this patient.
Yeah, so you have very rightly said that these markers are like echogenic cardiac focus and choroid plexus cyst, single umbilical artery, and urinary tract dilatation. These are 2 soft markers, and these soft markers, we do not need to go in for invasive testing. But if we have thickened nuchal fold or absent hypoplastic nasal bone, again they say NIPT can also be done in these cases. And this, but in our patient we had pylectasis also. So do we need to follow that pylectasis thing? How frequently we should do it?
Yes, I mentioned that if you counsel the patient, we need to, this comes under urinary tract dilatation. There's a classification. It comes in UTD A1, where the pelvic dilatation is less than 7 millimeters. Now, these are the patients, if the kidneys are normal, the parenchymal thickness is normal, the ureters are not dilated, the bladder is normal, and there's no evidence of oligohydramnios, as you mentioned, and the picture in the scan showed. These are the ones that only deserve a 3rd trimester ultrasound more than 32 weeks. And if it's stable, the size is not increased beyond 10 millimeters, we can safely carry on this pregnancy without any postnatal evaluation. However, if there's any deterioration at 32 weeks scan, then these are the babies that need to be seen postnatally, need an ultrasound and evaluation by a pediatric nephrologist.
Yeah, rightly said. So, ma'am, would you like to add?
Thank you, Reva. So as a non-fetal medicine specialist, as a basic obstetrician, what I understand is that there is importance of first trimester screening to interpret some soft markers which come up in the anomaly scan. So that can help us prevent any invasive procedure, or will help us kind of taking out or calculating an actual risk. So the management of the patient can alter So either if we don't do first trimester screening, then we better have our patients sent to someone who does not tell us about any more soft markers. Otherwise, we will do trouble. So that's what I understand. Yes, thank you.
Okay, so very rightly said. Now we will move on to our case 4. She is Mrs. A, 35-year-old, and she is G3P2L1. She visits the antenatal OPD at 9 months amenorrhea. She says she was in a native village and has come back to the city 15 days ago. She is not sure of her dates of her last menstrual period. On examination, the height of the uterus corresponds to 30 weeks. Her blood pressure is 140 by 90 millimeters of mercury. Her urine albumin is negative. So, Dr. Madhvi, may I ask you, how will you evaluate and manage her? Because we have no idea about her last menstrual period. And
thank you, Dr. Manisha. A very common scenario in our OPDs. So, management will definitely depend only on her gestational age. Now, coming to her evaluation, we will first try to ascertain what her gestational age is, because she doesn't know her last menstrual period. So we'll try to correlate it with some of her local festival, any previous antenatal visit, anywhere, any examination documented, of course, and any UPT done if she has any documented knows dates, what time was she given her vaccination and all. And then once we are, or then if we can take it to be either they are wrong dates or she has FGR. And I presume it's a live fetus, because another cause of not corresponding is intrauterine death also. So after this, either it's wrong dates or FGR. Once we decide, we do an ultrasound going with all her parameters for 3rd trimester, which are not very accurate, but yes, a BPD, head circumference, AC and femur length, the estimated birth weight, and also the LycoRed. An examination will include any signs, whether it's because her BP is a borderline blood pressure with no urine albumin. She has edema anywhere, abdominal wall or pedal edema, which would give us a indication, not certain, that yes, she's been having hypertension for some time and could be having uteroplacental insufficiency. So once we estimate her dates, either wrong dates, then we can continue her pregnancy as it is. And our clinical examination will also help us in the sense, the bulk of the fetus, size of the head, consistency of the head will help us. And in 3rd trimester ultrasounds, although the parameters are not very good indicators, but there are other parameters which we do not use commonly, like ossification centers of the epiphysis of the femur, distal femur, proximal tibia, and proximal humerus. They are not very accurate with the gestational age, but when we do not know the dates, they can be quite helpful. So if it's wrong dates, her pregnancy can continue monitoring her blood pressure and managing as and when the blood she requires an antihypertensive. And if it is dates are correct, she's already 9 months completed, that is around 38, 39. Of course, we will do a Doppler and decide whether she can be given a vaginal delivery or she needs to go in for a elective cesarean. And before the ultrasound, of course, whatever we can see for her anomalies, we need to do at this stage, whatever is possible. I think that is it.
Yeah. And is there a role of doing a consecutive scan again, like after 2-3 weeks, if we do it again?
No, that is only possible if her dates are not term, because 9 months completed, that means around 38 to 39.
Yeah.
So then there is no time. If we take it as wrong dates or somewhere more than 30 weeks, then we can do her growth can be seen by a serial growth at 2 or 3 weeks later. Then we will have a fair enough idea, but only if we have time, and we do not, our clinical estimation and our ultrasound does not take her to be around 38, 39 weeks.
Yes. So basically, what is the importance? And you have already mentioned the sources. So I had just listed that. So I'll put that also. But the importance of having the dating at the first visit, it is always there, isn't it?
Yeah, because it's dating which decides her pregnancy management, be it a low risk or a high risk. So even in a low risk, when you need to deliver, and interestingly, it's unreliable menstrual dates itself makes increased risk for adverse pregnancy outcome. So if we do not know, if we know the dates, because the earlier the patient comes to you, whether a menstrual history, even if her recall is very good, you do an ultrasound dating, and that error would be less when you do a first trimester ultrasound by CRL. That would be better. So dating is of course important: history, examination, and ultrasound. These are normally we use these 3 methods to date. So that is it. And if we have enough time, and then we can do a serial monitoring to see for growth and how the growth occurs between the 2 ultrasounds, and then we can have a fair enough idea about her dates.
Yes, ma'am, would you like to add? Yeah. So thank you, Madhvi, for the inputs. I think the importance of this case is to re-emphasize the importance of early registration and dating in early registration. So Madhvi, you've rightly said that even if the LMP is, she comes out very confidently with the lady comes out with LMP, it may not be correct. So we have to emphasize on that basic fact, whether the last period was a normal period or not. Sometimes they would have a, lighter period, and they might be kind of wrong dates. So whatever sources we have, we should kind of make sure that we do a good dating at the first visit. In another anecdote, some candid here, I can share it with you, that, what we see is that people write down LMP and dates not known, and it goes on and on and on. In the end, the dates are not.
Yes, it does.
Right. So I think this is an exercise for all of us also. So
ma'am, more so when we have a very heavy OPD and a resident happens to have such a patient. So it will go on and on till the time she is admitted in labor.
So I think it's very important that we make sure that we make a good assessment of gestational age whenever the patient comes to us. And then, if it is poor dating, then we keep keeping the growth in mind and correct it in case we find anything additional which would be useful for dating. So dating, very important. Yeah,
ma'am, even if her menstrual history recall is very good, but there's a lot of variation. Ovulation, fertilization, and the interval also between ovulation and implantation. So if we have a first trimester scan, that is best.
Yeah. No, even if we don't have, my emphasis is that even if we don't have,
yes, looking at the limitation of resources and the volume of patients we have, we may actually not have.
Ma'am, can I add one thing?
Yeah.
Ma'am, like if it is IUGR, we'll have associated oligo hydramnios to support sometimes. Then we'll have placental maturity also we should see. If it's grade 3, whether it's term or not term, preterm, that can also guide us. Like that things we can use our during ultrasound to go towards whether to go towards IUGR or whether we go towards a normal case. Wrong dates.
No, I fully agree with you, but sometimes despite all that,
yes, ma'am, that is there. Yeah.
We will go back to something very basic, like for doing a PV and feel for the head.
Maybe.
One could go up to that. So I think all this should be circumvented. If a patient comes to us, whenever she comes, be it first trimester, second trimester, we must do a dating. In case she comes to us in the second trimester, and let's have 2 consecutive ultrasounds and take an average of that after a fortnight. So we should use all opportunities at the first visit to date. That is what is my opinion. Sangeeta,
one thing I wanted to say was, though maybe not too relevant in this discussion, but even in clinical examination for patients who are coming to us, a serial symphysiofundal height measurement and plotting growth charts is very, very important to pick up FGRs. It is, I think, a myth that people say symphysiofundal height charting is not picking up. If you do it sincerely, if you plot it on a chart, at least in my OPD, I'm picking up.
No, Sangeeta, we have introduced that. We have put it on the antenatal card, like a growth chart for the babies. We have it on antenatal card, and we not everyone is doing it, but I think that's a very good practice. I personally feel it's a good practice.
We are really not, having touchwood stillbirths because of late FGRs.
I fully agree.
We are able to pick them there, price them with an ultrasound, and we are not doing universal scanning for growth for everybody. I had a discussion with Manisha.
Yes.
We can't do it.
Yeah, so we will quickly move to case 5, which is a very interesting case, and it has been provided by Dr. Sumitra to us. So she was a 21-year-old G2A1. She presented at 32 weeks period of gestation for an ANC booking. She was diagnosed as rheumatic heart disease 5 years back. She underwent double valve replacement, mitral valve and AV valve. She was NYHA class 1 and modified WHO category 3 with gestational hypertension. She was on warfarin, enalapril, ecosprin, and tab-emifru, which includes amlodipine and furosemide. So she did not remember the dose of warfarin she had taken in the first trimester. So what are the disadvantages due to late booking in this case, Dr. Sumitra? For both for baby, first, if you can tell us about the fetal side effects first, and then about the maternal complications later.
Good evening, everyone, and thank you very much for this kind invitation to join this really nice webinar. Just a small correction that I'm not in charge of the fetal medicine. Dr. Renu Arora is, and I'm faculty with her. We are taking this forward. So thank you for the case 5. Yes, we had managed this case at our institute. And what are the disadvantages due to late booking, both to the mother and to the fetus? She's presented to us in the 3rd trimester. The biggest disadvantage is that she's already on, the whatever we could have optimized prior to conception or even in the 1st trimester, we have lost that period. Now she is already on certain drugs which she should not be taking, like enalapril. And we don't know what is currently, whether we have been able to optimize her cardiac condition. And then she is also on a certain dose of warfarin, which she doesn't know what she had taken in the 1st trimester, which could have also had this adverse effect on the baby. So effect on the baby due to the drugs, as well as effect on the mother on certain drugs which she should not have been taking at this time. And her own cardiac condition, it is very important to know that, whenever a lady has undergone a double valve replacement, the type of valve which has been replaced, then the number of valves, and also the duration. Like she's undergone a replacement 5 years, and more than 5 years if it was, then the valves would undergo wear and tear, they would become older. And then also the type of valve becomes important, because even in the mechanical one, there are different types of valves. Like there is a bi-leaflet, then there is that St. Jude, and then there is the ball cage, and another one which is the tilting disc. So they have different types of risk associated with it. So it is very important that if she comes at a certain time, we are able to categorize her, because she will of course be in the modified WHO category 3. We should be able to categorize and risk stratify her. What do I mean by risk stratification? I need to know how long the valve replacement was done, what is the type of the valve, then what is the current condition, that is the echocardiography, what is the valve function, and if she's had any thromboembolism, any event which has occurred in the past, currently, what is the left ventricular ejection fraction, if there is history of fibrillation, so, and if there is of course any other associated comorbidity. As we can see in her case, I think she also developed gestational hypertension. So she had been started on enalapril, which we know that that can have an adverse effect on the fetus. It can lead to renal dysplasia, oligoamnios, and affect the baby. So these things we could have done earlier if she had presented to us. We could have optimized we could have changed her over in the 1st trimester itself from warfarin to LMWH. We could have optimized her own cardiac medications. We could have monitored her, correctly, and brought her to this 32 weeks in an optimal condition with the best outcome for the baby also, for the fetus also.
So now how would you manage her, and how you have managed already? Yeah.
So at 32 weeks, then the first thing is that the management is always multidisciplinary. We need to have a team of, CTVS, then cardiologists, neonatologists, hematologists, and of course, we the obstetricians. So the entire team has to look into this case. And with the opinion of the cardiologist, the drugs were modified and she was moved to Lasix, 20 milligrams BD. And then when we saw her INR, the INR was not optimized. As I said that, depending on the type of the valve which has been replaced there and the number of risk factors which are present, she will be categorized into low, medium, or high risk. So according to that, the INR also has to be optimized. So in a low risk patient, it is between 2.5 to 3. And accordingly in higher risk, it goes even higher. So in the high risk category, it is 3.5 to 4. So we saw that even the INR was not, at the requisite level. So that we had to increase the warfarin dose and monitor the INR to optimize that too. Then we had to, of course, closely monitor her because she will be at risk of thromboembolism, atrial fibrillation, and of course sepsis. So and associated any other comorbidities because she was developing high blood pressure, so preeclampsia. So all that maternal monitoring needed to be done. Then the fetus had to be monitored. The fetal monitoring, we looked at the ultrasound. The fetal weight was, I think, yeah, somewhere between the mean and 50th centile. However, the ultrasound reported a small nasal bone, which most likely could have been due to the warfarin, which, unmonitored warfarin, which she must have taken in the first trimester. So the fetal monitoring, what we do in the antenatal period, that only we need to do, nothing very extra, but the ultrasound parameter was pointing towards that maybe this fetus definitely could have been affected because of the drug which the mother had taken. And with close monitoring, we could take her till we had decided that we could, we would have to have a very controlled termination. Of course, she had developed gestational hypertension, because of which we needed to terminate the pregnancy around 37 to 38 weeks. And secondly, why we need to do a controlled termination by planning an induction is because she is on low molecular weight heparin at that time, and she needs to be changed over to something which is even shorter acting. Meanwhile, mind you, at this time, she's at risk for preterm labor, and she is on warfarin. That is one challenge which is already, we have been able to take care, because we've changed her over to LMWH at 36 weeks. So that is one thing we need to do, is we change her over to LMWH at 36 weeks. Now, when the patient is on LMWH, we need to monitor the anti-10A. And luckily at our institute, the hematologists have brought this in, that we were able to offer this to her. So because of that, then we are able to get a very good control. We know that, on LMWH, if my anti-10A is between 0.8 to 1.2 for a mitral valve, for an aortic valve, it is a bit, longer, this thing, but she's on double valve. So we have to keep a very narrow margin, that is between 1 to 1.2. And the anti-10A has to be done, most studies say that it should be done around, 4 hours after we have given the LMWH. She's on a therapeutic dose of LMWH. So 4 hours after the dose is given in the daytime, we repeated the anti-10A and tried to bring it as close to the therapeutic margin that it should be. And at that, so we tried to bring her till 36 weeks on LMWH, and then we changed, at 36 weeks, we changed her over to LMWH, and then we planned her delivery. Now, again, as I said, the delivery itself becomes a very big challenge, because what is the therapeutic window when I should stop the anticoagulant, because she's at a very, very high risk of, throwing an embolism. So I need to have a very narrow window where she's off the anticoagulant and I'm able to give her a safe delivery. So for that reason, we changed her over to unfractionated heparin, which has a very short life, shorter half-life. So what we did was that at 38 weeks, we planned the delivery by doing induction. We had done the pelvic assessment and we planned the delivery by doing induction of labor. Now, there are two schools of thought that how do you do induction? Do you do a mechanical or do you do a prostaglandin? Because if you give prostaglandin, you may cause, decrease in systemic vascular resistance and tachycardia, which may lead to, become a risk factor for failure. But here in this case, we did use prostaglandins, and so when we decided to do the induction, we changed her over to unfractionated. So unfractionated, we have to give a loading dose of 80 units per kg body weight. And after that, we keep her on an infusion of 18 units per kg body weight per hour. So on this infusion, the patient has to be monitored by APTT now. So we can do an APTT after 4 hours to see, we tried that the APTT would be more than or equal to twice the normal APTT. Now, this infusion, she received 2 doses of dinoproston gel, and then she luckily for us went into labor, and we stopped the heparin infusion around, we planned to stop it around 4 to 6 hours prior to delivery. So when she was around 6 centimeters, anticipating that the delivery would happen. In that time, we stopped the infusion, and of course the careful monitoring which goes into labor was followed. As in a case of heart disease, we all know what all needs to be done, cutting short the second stage of labor and giving her Lasix, and then
Yes, so basically because we are running short of time.
Yeah,
So basically I understand that you emphasize that we have to, deal with the patient before pregnancy occurs, but throughout the pregnancy, we need to give her better care. And of course, the delivery time is the most important time for her, and as well as the post delivery period. So ma'am, would you like to add something?
Yeah, basically, I think what we need to understand is again emphasizing on pillar 5, the medical disorders. So it is that, any patient who's got medical disorders, it is important to evaluate them preconceptionally. And in case it is not possible to do it preconceptionally, we do it in the first trimester. And the importance of good postnatal advice. So even if they deliver for the next pregnancy, please don't miss that opportunity and think that next time, the person who looks after will take care. So I think it's important that we make sure that whenever we come in contact with the patient, we tell them as to if they become pregnant, what is to be done and what should be done before it and what should be done after that. Thank you.
So there is a depressed nasal bridge and stippled epiphysis that you have very rightly shared with us, Dr. Sumitra. So let's quickly go on to case 6, the last case. She was 25-year-old G2P1L1. She comes for a first antenatal visit at 28 weeks with over-distended abdomen. On clinical examination, the fundal height is 34 weeks and there are multiple fetal parts were palpable. Ultrasound was done and it showed a twin live fetuses. So Dr. Rachna, would you tell us what information is desirable on ultrasound for optimum management of twin pregnancy?
Thank you, Dr. Manisha, and thanks Dr. Sangeeta and the team for inviting me to such a practical discussion on the common problems we deal. This case is of twin pregnancy who's unfortunately being diagnosed at 28 weeks. So now the first thing we'll like to confirm on ultrasound, the twin pregnancy, and the most important thing would be to know its chorionicity. Now the chorionicity will be a challenge. If we are lucky, and we are able to see dichorionic, diamniotic, we are the luckiest person, because most of the times, even if it is dichorionic placenta, it gets fused and appears as a monochorionic. So the next challenge would be to see the interamniotic membrane. There is no definite cutoff to say that a thick membrane is definitely diamniotic, because it can be diagnosed, as said in the previous panel, very nicely at 10 to 13 weeks. But at this gestation, it would be another challenge. Then if we are not sure of whether we are dealing with the monochorionic or a dichorionic, next we might be lucky to see the sex. If it is different sex, we are sure, almost sure, that it is a dichorionic placenta. But if not, then we'll have to keep an R on the side and follow up the case line, deal with the challenges and look for the problems associated with the monochorionic placenta. So next would be my aim to look at first identify and label both the fetus, define which is first or right or left, and basically, and then follow the fetuses and see for the discordancy in the placenta. Placental, like we'll have to see whether one placenta is thickened and the other is maybe starry sky appearance, or some problems we are anticipating for the monochorionic placenta. Then we'll have to see for the Doppler indices and look for the middle cerebral artery peak systolic velocity, whether there is differences in the two, so as to diagnose, trap, look at the amniotic fluid index in both the sacs, whether there's any discrepancy. One is oligo, other is poly, to look for TTS, or trap. In terms for the trap, we have to look for middle cerebral artery. When there is difference in the discrepancy in the middle cerebral artery peak systolic velocity, we might think of the anemia polycythemia syndrome, or we look for a cardiac twin, that is trap. And the next would be obvious, seeing the selective fetal growth restriction by measuring the growth indices of both the fetuses. So if it is dichorionic, diamniotic, we are assured and we can manage as then. or if it is monochorionic, we'll have to look for these 3 major complications. And then we have to be very surveillant about the various complications other associated with twins in the form of preterm labor, in the form of development of preeclampsia, or then we may have GDM developing. So we will have to be look on out for all this. And then we have to do repeat scan 2 weekly, especially if it is monochorionic, and look again for LycoRed biometry and Doppler.
So if we have a doubt whether it is monochorionic or dichorionic, we will take her as monochorionic only, and we will deal like that only. So this is the main point. And as you very rightly said, that we will look for the complications. This is, I think we don't have time for other queries. And so we will just close here, going to the conclusion. Nothing much, many things have already been said. So I would just conclude by saying that the antenatal care serves as a key entry point for pregnant women to receive a broad range of services and should be initiated at the onset of pregnancy. It is a duty of healthcare provider to appraise women to come early or even during the preconceptional period. Quality of antenatal care also plays a great role in ensuring that the purpose of antenatal visit is fulfilled. So quality is also important. And even if the woman comes later in gestation, best possible management should be provided. But even the best care can sometimes not make up for the lost opportunity. Thank you so much. Thank you, everyone, for patient hearing.
Thank you for having us here.
Thank you.
Hello, good evening, everybody. First of all, I'd like to thank Dr. Sangeeta and Dr. Asmita for, planning this wonderful webinar, and wonderful talk by Dr. Shakun, and excellent panel by Dr. Dr. Kamal Gujral and Dr. Sangeeta, and very practical case discussions by Dr. Manju and Dr. Manisha. But I would just like to make few important points. One is that, when we talk of antenatal care, it has to be a holistic approach. And it has to be, when we are thinking of changing the pyramid, inverting the pyramid, we have to increase the public awareness. We have seen that we started this premarital and prenatal preconceptional clinic in Safdarjung Hospital by the name of NEEV, about 60 in 2016, but still the most of the cases which come to the clinic are those who have had an adverse event. So that is what we have to emphasize on. One time I was thinking that we should advertise about these clinics in the marriage sites also, shadi.com and all those things, so that probably it will pick up, but that really is lacking. The preconceptional counseling and the premarital counseling is really lacking. So we have to encourage on that. And then the antenatal care also, patients, they will come 3-4 times in the last trimester, but they will not come in the second trimester or third trimester. Only one week difference is there in the 2 visits. So that also has to be emphasized about the number of visits and how it should be done. The second point, what I wanted to say, that we have been talking about so many biomarkers and so many things, but we first think of doing a clinical examination. I have seen patients being referred for ultrasound in first trimester. Ultrasound date is given for 1 week and you miss an ectopic pregnancy. So this, I think we have to, if you think that ultrasound and technical things are not possible, please just don't leave on that. Please do your clinical examination completely. And even measuring as Dr. Manju was also saying, that equality of antenatal care, when we talk about, they don't even, put the hand on the, fundal height, just send the patient for ultrasound. FGR hai, nahi hai. I mean, that is secondary, nobody sees so I think clinical things have to be really, taken importance. Third thing, which Dr. Manju has also said, about, we have got Lakshya for antenatal, for labor room care, OT care. You know, we have got standards for Lakshya, but we have no standards set for antenatal care. I think Dr. Manju, I also put this in the ministry also, but you are looking at the quality management in, AOGD also. So I would like you to make standards for antenatal care, especially for BP taking, as Dr. Kamal also very nicely said. You know, I keep on asking when patients come to me, how your OGTT was done. If you look at the OGTT report, the patients will say that 1 घंटे के बाद blood ले लिया, आधे घंटे के बाद blood ले लिया, किसी ने खाया, किसी ने 50 ग्राम glucose भी नहीं खाया. So I think these are the very important things, you know, we have to really focus on to quality of antenatal care, and we should make a standard checklist for these that should be really available in all the institutions, small or big, and if that will really curtail, you know, the complications. That's my feeling. And fourth most important thing which I thought was that mental health issues we have to always, you know, consider, which we do not, we just forgot on the, you know, technical issues and with all the biomarkers and everything. I think mental health issues have to be really taken care. And last but not the least, prepare the patient for postnatal care. That is not, you know, generally we just focus on contraception only in the antenatal care, but even preparing for the facing the complication, and even if you have an IUD, you know, bereavement counseling. So if I think that discharge slip of the patients should always be seen by the senior people also. Intern banata hai discharge slip, and what is written, whether when she will, especially with the IUDs patient, you know, I have seen that they don't even tell her कि next visit में आपको folic acid शुरू कर देना, ये कर congenital anomaly. So these small things, you know, that will make a lot of difference, but we have to focus on that. That's my, you know, say, but wonderful webinar, and I've learned so much. I think every point was comprehensively dealt with and everything was very nicely described. Thank you very much.
I don't know what to say, but technically I can say that yes, it has been a very good topic. You know, inverted pyramid of care, the name signifies everything. And in this, you all have discussed the standards of care with the current evidence-based guidelines. So I'm so happy to see that, you know, most basic things, which we actually, you know, when the patient comes to us for the fetal perspective, and we realize that the maternal issues, there were so many maternal issues, you know, which were missed clinically just because there was one echogenic intracardiac focus. But, you know, the patient has been referred to us, but there has been, you know, the issue of hypertension, diabetes. So I'm really happy that, you know, actually, as ma'am has already highlighted, I would like to re-highlight that, you know, the clinical assessment of the patient, it's not only just fetal or maternal, it's combined. So as a clinician and as a good clinician, we need to have the, you know, good knowledge of both the maternal issues as well as the fetal issues. And it's time that, you know, the things are changing very fast. So the fetal issues are evolving. So we need to update ourselves. So today you have highlighted everything, you know, which a clinician actually, a good obstetrician needs to know. So both the maternal aspect and the fetal aspect. So just few common, you know, few important things which I would re-highlight. The one is about the carrier screening. So in the carrier screening, you have to screen both the genetic and non-genetic. Non-genetic, you know more better than me. So in the genetic, I would just like to add that, you know, the SMA, in addition to thalassemia, which we have been discussing for ages, that because the incidence is 5%, the SMA is no less. It is 2 to 3%. In Delhi, the incidence is about, you know, in a study by Gangaram, they quoted the incidence as 2.5%. So this is very, very important that now we should, you know, make ourselves, you know, sensitized towards the screening for the SMA and CAH as well. CAH is little cumbersome. So at least one addition from today, at least we can inform them that now these tests are available, because so if the child gets SMA, then probably we are also responsible. So because this is a common thing. Then regarding the, you know, the combined screening, the combined screening still holds the big role, even despite the cell-free fetal DNA. It's a cell-free fetal DNA is a very powerful and efficient test. but we should not bypass the combined screening. Both should be used together. It's not that, when something good comes up, let's bypass the combined screening, because that's what I am seeing. I'll ask the patient that, okay, this is cell-free fetal DNA, where is the dual marker? No, that was not done because this was 99% sensitive. So no, this is not the, we have to do the basic things first, then only we should move to the advanced technology, because we know that, this gives immense information other than the Down syndrome. So it may give you the information of other uncommon aneuploidies which the NIPT may not be able to. Also, that this gives you indication of the adverse perinatal outcome. So it's important that let's start doing the combined first trimester screening. And if you have a facility of PLGF, yeah, that is talking of too much, but you can screen even for the maternal preeclampsia, even with the association of the PAPE also. So these these things are important. Then regarding the soft markers, so it's a very common referral for us that soft markers has been identified, and a good detailed sonogram, and followed by the discussions that this means, like for example, echogenic intracardiac focus, a discussion about what the soft marker echogenic intracardiac focus means, and how much is the incidence like in the general population and in the it's common, and at the end, just a passing remark for the cell-free fetal DNA, because very occasionally it may be that, so this will complete we should not say that, no, so your dual marker is okay, your quadruple is okay, and there is nothing else, so nothing will happen. Because at times you may find that this child is a, Klinefelter syndrome, or this child is a, some other chromosomal abnormality. So because of the technology available, we have to just give a, information, not that we have to pressurize them. Then regarding the twin pregnancy, we have beautifully highlighted that the chorionicity is the most important part. I would just, re-emphasizing, because most of the ultrasound which I get will just write a twin pregnancy scene. They will not write whether it is a dichorionic or monochorionic. And why this is important? This is important to determine the risk. For the dichorionic, this is a low risk twin, and monochorionic is a high risk twin. So immediately, the moment you get to know this is monochorionic, you would refer to the higher center. But dichorionic can be managed at a good obstetric care center, like all the government setups which I can see that they can manage. But for the monochorionicity, you need further advanced care and to refer to the proper fetal medicine specialists. And then regarding this, NIPS. So in the twins also this is possible, but we have to see that if we are doing it for the dichorionic twin, we have to counsel them that this may be discordant, and then the further, the invasive testing and all is required. So I think you all have covered all these important topics, and I'm sure this will make a big difference in the practice of all those who have attended today. So that's all for.
Thank you, ma'am, for your comments. We'll now proceed to the Q&A session, and it will be taken over by Dr. Dipika.
We have a bunch of questions here. Few have been answered live. So I'm taking up those questions which haven't been answered, and this is for the panelists of first session. So one of the questions by our attendee is, should fetal echo be included in universal antenatal screening in higher socioeconomic setup?
I think care has never been stratified according to the socioeconomic status of the patient. Probably it may be justified if the women are obese. In obese women, yes. You may high BMI women, yes. But please don't make these kind of stratification of risk. Antenatal care, every woman deserves equal and good antenatal care.
And when an anomaly scan is done, the 4 basic, heart views has to be taken.
In fact, here
so that
I would like to say that it is so common to get the soft markers referral. There are three very important things. The kind of case which Dr. Manisha has presented comes 1 or 2 every week in my clinic. So one problem is that the scan then is so shabby. And whenever it's an echogenic intracardiac focus, please make sure that all the cardiac views done in that scan are normal, because it is associated with anomalies also. So I don't refer for a fetal echo, but I ensure that the cardiac views which are recommended in a basic anomaly scan are properly done. Otherwise, no cardiac views are done. Only a fetal echogenic cardiac focus is reported, and the patient has sent here for us to keep on counseling. Another problem with your soft markers is they will see one, they will report one. They will never report the others. It is equally important to report the others to have a negative likelihood ratio. So please, that is why we are trying to educate everyone, because unless we start asking for the right things, the sonologists won't give us the right information. That is why we need to educate ourselves. And I just want to add one more thing about thalassemia. That if there is a concomitant iron deficiency anemia, serum ferritin cutoff of 15 should be taken. Any patient who's less than 15, supplement iron. Otherwise, it's not good to give a prophylactic iron to this thalassemia minor patients also. So we should be careful there, not do a universal supplementation like the non-thalassaemic population. Third, in patients who are straight, please encourage cascade screening. You have to tell them their SIBs and other family members, because that's how
very important.
Yeah.
Absolutely.
So I think that has been answered, but Dr. Sangeeta ma'am, just one thing which the attendees would like to know, that are there any particular conditions where they should order a fetal echo? So the message is clear to them where they should order.
Yeah, all diabetics, and that too not diabetics who are controlled on diet. If they are well controlled, you don't need it. But patients who are on insulin therapy or who are not controlled, other candidates, or patients who have had previous babies, previous SIBs with or family history of
mother. It has to be pre-gestational diabetes. It has to be pre-gestational diabetes.
Any teratogen.
And if there is any other anomaly which is present, then we must get them.
Anomalies.
Parental congenital heart anomalies also qualify for screening along with IVF gestations and monochorionic cysts.
Yes.
History of teratogenic drug intake.
Yes. Yes, that's very, very important. Yeah, if you're all anti-epileptic, you need to, refer them to us.
Yes.
So I think the message is very clear here. And so we move on to the next question. That's also for the panel, both the panels. Anyone could go for it. What is the role of soluble FMS tyrosine kinase in predicting preeclampsia?
So basically, when we use SFLT and PLGF, we use it as a ratio. So it is generally advised to be done in the later half of pregnancy, when we want to see whether there are any adverse outcome of that hypertension or preeclampsia will occur or not. So generally, if the ratio, there are two cutoffs. So generally, the consensus now is to take 38 as cutoff. So if the ratio is more than 38, then we can keep those women as in high surveillance, so that these women might land up in preeclampsia. If the ratio is low, then we can, even if the patient is high risk, we can just keep them like they are not known to develop preeclampsia at least before 37 weeks. So that is it.
Yeah. So basically, I think it helps you stratifying patients who have to be inpatient and who have to be outpatient. So, and it gives you a window of 1 week. So basically, if they have a high ratio more than 38, then we expect, we think that they are the patients who are likely to have complications. So they should be inpatient. And those who have less, then we can comfortably, we have to monitor them, but they can be kind of,
And there's another ratio of 110 which is taken. So if it is 110, then definitely they are going to have some problem within a week or so. So
predictive value for 1 week is very good, that the patient will not have
anything, within 1 week.
And so one can avoid preterm delivery. In fact, hospitalization
primarily for stratifying risk.
So that can help us in giving the ambulatory care, and 1 week is a good interval if she can have the ambulatory care. So,
and also not give steroids unnecessarily. That is another very important thing.
That's very right.
We keep giving them thinking that you might have to induce. So this may not be a clinically practical, keeping in mind the cost factor, but it is there. It has got a good negative predictive value.
Yes.
And similarly, glycosylated hemoglobin, which is being said now in preeclampsia, what's its role?
Another biomarker.
Yeah. Which is being used to stratify whether the preeclampsia will get complicated or not. It is being now as available in market also.
I'm not.
As it is.
Okay. I think
but recently I think after COVID they have even shifted to NLR ratios and all the those cost-effective values. CBC could even also predict. So these are the upcoming things like
upcoming. That's because COVID was mimicking preeclampsia, no? So that's why it came.
Yes. I think that's all the questions we have, and over to you, Dr. Shakun, for the vote of thanks.
Thank you, Dr. I'll start my. First of all, I would like to thank Dr. Asmita for guiding us all through the star and giving us this opportunity. I'd like to thank Dr. Sangeeta Gupta, and she's been main force behind the whole NARCHI tenure as well as this workshop. Panelists for their cooperation and valuable cooperation. I'd also like to thank all the delegates for making this CME a success. And I would also like to thank all the faculty of our department and my unit for all the support. I'd like to thank Dr. Niharika and Dr. Chetna are also a very important part of this event. I'd like to thank the residents and fellows, especially Dr. Soumya and Harshiba, who have really participated very intensively in this workshop. And the sister in charges, Gynae Ward and Mr. Jay for their venue and the related audiovisual. And would like to thank Dr. Tripathi and Dr. Batra to come all the way here and
bless us.
Bless us. And Dr. Manju. Dr. Manju and Dr. Monisha to come here. Last but not the least, Jagsonpal Medical Services for providing technical and platform related support. So, Mr. Ankit, please take over.
Okay.
Thank you.
Yeah. Okay. So, on the behalf of Jagsonpal Pharmaceuticals Ltd, I would like to thank you everyone for joining us today and look forward to join us in the upcoming webinars of ours. Thank you very much.